go ahead and get started. Good afternoon. Thank you all for being here. It's a great pleasure to have this first Global Cancer Symposium at Duke. I just wanted to start by a word of welcome and thanking for the people who actually put this together. So Kelly Deal, Agata Roca, Sarah Stuckey, Jennifer Kaczynski, Amy Pearson, Joel Ross, and my co-lead, John Bartlett, with funding from DGHI and DCI, as well as the School of Medicine. I really want to extend a warm welcome to our speakers who have traveled far and wide to come here. So it's actually should be a very exciting afternoon. So I thought I'd make a logo for Global Oncology at Duke. So this is our logo, and it's for Go Duke. So, without further ado, it's a pleasure to introduce Dr. Mike Kastan, who is our director for the DCI, and come up and introduce our first keynote speaker.
So, welcome to the first Duke Global Cancer Symposium. It's quite exciting, and we're thrilled that we have such a nice turnout, and I'm sure it will be the first of many. We're so pleased with the partnership between the Duke Global Health Institute and the Duke Cancer Institute that led to the creation of Duke Global Cancer. We're also thrilled that Dr. Nelson Chow agreed to be the inaugural director of Duke Global Cancer. And this symposium is the first of many activities and functions that will reflect Duke's commitment to global health and global cancer. Cancer is truly a global public health challenge. First of all, 8.2 million people on the planet died of cancer in 2012. It's anticipating that cancer will become the #1 disease killer worldwide in the next few decades. Second, at least 30% of cancer deaths worldwide are related to lifestyle choices, including smoking and diet. Third, viruses such as hepatitis viruses and human papillomavirus are responsible for up to 20% of all cancer deaths in low and middle income countries. This provides significant opportunities for effective prevention. Let me say that again. This provides significant opportunities for effective prevention. I'm sure this will be a major focus for all of us going forward. And fourth, greater than 60% of all cancer deaths worldwide occur in Africa, Asia, and Central and South America. The vision statement of the Duke Cancer Institute is to transform cancer care through innovative research, seamless integration of academic and clinical missions, and compassionate care with hope, healing, and cure. This vision includes global components, such as that the DCI will be among the very best cancer centers in the world, and that the DCI will have global reach and impact. And we can't have that global impact without having significant activities on a global scale. In fact, already today we have institute-wide activities in Pakistan, Singapore, China, and Tanzania. And we have investigator-initiated activities in China, Nepal, East Africa, Haiti, India, Kenya, Taiwan, Tanzania, and Uganda. In today's symposium, we're going to hear about cancer challenges in Africa, Brazil, China, and India. I'm sure it'll be a fascinating afternoon for all of us. But I'm now honored to be able to introduce our keynote speaker, Dr. Ted Trimble. In September 2011, Dr. Harold Varmus appointed Dr. Trimble as director of NCI's new Center for Global Health. Dr. Trimble, a graduate of Harvard College, earned degrees in medicine and public health from Johns Hopkins University. He trained in obstetrics and gynecology at Vanderbilt University Medical Center, and then in gynecologic oncology at Memorial Sloan Kettering Cancer Center in New York. He's been recognized internationally as an expert in prevention, screening, treatment, and symptom management for women with cervical, ovarian, uterine, and other gynecologic cancers. Since Dr. Trimble joined the NCI in 1991, he has led NCI's National Scientific Program of Treatment Trials for Gynecologic Cancers and has worked with colleagues worldwide to develop global research strategies for these diseases. He coordinated 2 of NCI's clinical announcements to focus attention on NCI-sponsored research findings that changed standard clinical practice. The first, in 1999, improved chemoradiation treatment for women with cervical cancer, and the second, in 2006, changed intraperitoneal chemotherapy for women with ovarian cancer. Together with colleagues from the National Institute of Allergy and Infectious Diseases and the National Heart, Lung, and Blood Institute, Dr. Trimble organized the Trans-NIH International Clinical Research Subcommittee, which has worked to strengthen international collaboration in academic clinical trials. For his work at NCI, he has been awarded the 2 Public Health Service Commendation Medals, 6 NIH Merit Awards, and the NCI Director's Gold Star Award. It's a pleasure to introduce Dr. Trimble, whose lecture today is National and International Efforts in Global Cancer. Dr. Trimble.
Thank you very much for that introduction. I'm delighted to be here, and I want to say, as I go over some of the priorities that our center is working on, that you know, in part we've been inspired by folks such as Mike Merson and other colleagues in global health who gave us terrific advice when we got started and some guidance on how we can best move forward. And I'm also happy to have Nelson Chow as someone that we can call upon for help. We've actually recruited him to help us evaluate bone marrow transplant programs at the King Hussein Cancer Center in Jordan next month. So our center was formed by Dr. Harold Varmus about 2.5 years ago. And one of the first things that Dr. Varmus wanted us to do was to organize a stakeholders meeting to give us advice. And so we invited people from other NIH institutes, from CDC, from PEPFAR and USAID, and from their cancer centers to give us advice on where we should focus. We knew we were kind of at the intersection between research and public policy, and how could we have the greatest impact. So these were the themes that we came up with, and I would like to take this opportunity to kind of go over these themes in a little more detail. This was also being done in a setting where there's a global attention focused on NCDs. Finally, there was, as many of you know, in 2011, the UN convened a high-level meeting on non-communicable diseases. This was the second high-level meeting that the UN has convened on health, the first about 10 years earlier on HIV. And the UN charged the World Health Organization with developing an action plan for NCDs. And their action plan was presented to the World Health Assembly last year. The World Health Assembly approved it, and they're now figuring out how best to develop a oversight committee involving as many UN agencies as possible, as well as how best to involve civil society in this action plan. In addition, the World Bank, which has now for more than 10 years looked at the intersection between health and economics, has added NCDs to their list of disease control priorities. And there's also been an effort, thanks in large part to the work of Chris Murray at the University of Washington and his colleagues, in developing an ongoing assessment of disease around the world called the Global Burden of Disease, which looks both at morbidity and mortality, disability-adjusted life years, and it's clear from the work of that group that cancer does convey a major burden in most countries of the world. And if one looks at the World Health Association, organization, global NCD targets, you'll see that the things relative to cancer can, probably the most important one here is a 30% goal for 30% reduction in tobacco use, one of the 0% increase in diabetes and obesity, increasing access to essential medication, decreasing alcohol, harmful use of alcohol, decreasing physical activity. So really, almost more than half of the NCD targets for 2025 have relevance for cancer. And the hope is that they will be able to reduce the mortality from NCDs by 25% by the year 2025. And this is a slightly more detailed list of the indicators that WHO has come up with. And as you see, in terms of the monitoring, they're recommending, capturing cancer incidence here, cervical cancer screening, hepatitis B vaccine, human papillomavirus vaccine, access to palliative care. So we have a number of the indicators. And the indicators are things that each country is expected to think about and expected to report back to WHO on how it's doing. So the first theme that fits into both for us as well as into the recommendations of WHO is terms of cancer control planning and implementation. And here we have organized what we're calling an International Cancer Control Partnership. This is the website, iccp-portal.org. And it was an effort to try to get people talking to one another and actually working together, because there are a number of kind of separate efforts through IARC in Lyon, WHO, the International Atomic Energy Agency, about 10 years ago started looking at cancer treatment. This is the International Union for Cancer Control. And then there had been an effort within the United States to help each state develop a cancer control plan. That was something driven by NCI, CDC, and American Cancer Society. And so the people who've been involved in that program had a lot of experience. So one of the things that we tried to do early on was to bring everyone together so that they could help give each country advice on how to develop a cancer control plan and hopefully figure out how to give them the technical assistance on implementing and monitoring that plan. So in terms of the critical pieces of these cancer control plans, one of the most important is how best to strengthen health surveillance systems. One of the things that we've seen is that surveillance has largely been siloed by disease. And so while we have a cancer registry, we often, in many countries, that cancer registry is not effectively linked to death registries. And we are tracking, we may have a separate HIV registry. So we want to work very closely with ministries of health to give them advice on how to strengthen their entire health surveillance systems with, obviously, an attention on cancer risk factors, on improving cancer registries, and improving links to death registries. Rollout of vaccination is critical. We've had good success rolling out hepatitis B vaccination, in large part because of the cost. The cost is now down to about 25 cents a vaccine, and it is widely given to children in the first 3 months of life around the world. In the countries where they've been introduced early and systematically, Taiwan is probably the best example. We're already seeing decreased rates of liver cancer. HPV vaccine, obviously, is more recent, and we're still wrestling with how to get that out. We haven't had vaccines to give adolescents before. It's 3 doses. It's relatively expensive, and so we have a ways to go in terms of getting HPV to as many people as possible. And clearly, there are a number of cancers that we can screen for, and we need to figure out both how to make those screening programs or to make them population-based, to make sure that they're of high quality, to make sure that they're linked to appropriate evaluation and treatment. But I think I think we can definitely screen for cervix, for colon, for skin, oral cancer, as well as to move to timely evaluation of breast masses with the technology and the knowledge that we have now. Another critical issue that often goes overlooked is that of improving access to and quality of clinical laboratory services. We've seen that what has been done effectively through PEPFAR, for example, in improving microbiology and clinical chemistry, and we know that to diagnose and treat cancer patients, we have to improve laboratory services. So that includes pathology, includes hematology, includes microbiology, includes chemistry. Hopefully we can build on some of the investments that PEPFAR has made, but this is a critical issue. We also need to improve access to and the quality of cancer treatment from a variety of disciplines, from imaging to surgery to chemotherapy to radiation to nursing. We know how to do this. We've obviously made great strides in the U.S., and I think we can help other countries improve the quality of that treatment. We need to improve access to standard drugs for chemotherapy and for supportive care. Again, there's some good examples from HIV and other infectious diseases through the WHO's program for essential medicines, where WHO has developed a list of what are the most essential medicines. They've then worked to identify companies that will pledge to make these products available at a kind of a bulk purchasing rate. And so countries now can buy through WHO and UNICEF and some of the regional WHO offices these essential medications. Some of cancer chemotherapy drugs and supportive care drugs are on the list. So we're working to see if we can expand that list, as well as to help countries figure out how to buy those drugs and make them available. We also need to help countries think about how to build effective survivorship programs, how to build effective palliative care programs, again, which we have learned how to do in the U.S., and I think we can share our experiences with other countries and help them think about how to do these more effectively. Next theme, and I've touched on this a little bit, is how we can build on the progress that we've made with infectious diseases. And so if we look at how we've been able to make progress, it's both from an investment in research, and certainly we've seen that major commitments to infectious disease research in the United States, both at the National Institute for Allergy and Infectious Disease, National Institute for Child Health and Human Development, at the Fogarty International Center, at our Office of AIDS Research, as well as through US CDC. And in addition, that research has been coupled with an effort to translate the research into public policy and into clinical practice through WHO and the UN AIDS, which Mike Merson helped set up, through the Global Fund, through the PEPFAR, the President's Emergency Plan for AIDS Relief, as well as a major commitment to help roll out vaccines through Gavi, largely supported by the Bill and Melinda Gates Foundation, and the Gates Foundation has supported many efforts relative to infectious diseases. So one of our challenges for NCDs is, while we've had a similar commitment to research, we have to wrestle a little bit with, or a lot, with how best to ensure that research to policy piece actually happens. We also know, as Mike Kastan mentioned, that chronic infections are responsible for many cancers in the developing world. It's estimated it's at least 25%. And of those, about 5% are associated with HPV, 5% with hepatitis B and C, and 5% with Helicobacter. And as I mentioned, we do have effective interventions or preventive strategies for two of these. We have vaccines for hepatitis B and human papillomavirus, and we know how to treat with antibiotics Helicobacter infection. Variety of other infections are still a challenge in terms of EBV, HIV, as well as some of the parasites, liver flukes, schistosomes. So what is the next theme that we've focused on, and that is how we can tackle some of the common risk factors for non-communicable diseases. So we want to both learn and build on what we've done in infectious diseases, as well as what we can do in common with those people who think about lung disease, think about heart disease, think about diabetes. And here the most obvious example, the thing that where we can have the greatest impact is tobacco. And people who live in this part of the world know a lot about tobacco, know a lot about social marketing of tobacco, know a lot about the role that that tobacco played in the economy of this area, as well as the health of the people in the United States. So I think it's important to remember that just as we had this UN meeting on NCDs in 2011, we also had this global framework convention in 2003. This is the very first World Health or treaty, a global treaty focused on health. And it's signed by 168 countries. It's legally binding in 178 countries. The two countries that I know that have not yet, where it's not yet legally binding, are Indonesia and the United States. And so we at NCI and NIH have devoted a lot of money into tobacco control research. We have what's called the NIH International Tobacco and Health Research and Capacity Building Program, which is a really good program that links universities in the U.S. with universities in the developing world to help them build tobacco research expertise. We also have been partnered with the FDA, and the FDA, as you all know, now has regulatory authority over tobacco and nicotine, and so they have partnered with NIH to develop what's called the Tobacco Regulatory Science Program. We also have helped sponsor the Tobacco or Health global and regional conferences, which happen, the global ones happen every 3 years. And we also help sponsor the meetings of the Society for Research on Nicotine and Tobacco. I like this ad for Bull Durham, in part because it shows the importance of price and tobacco. This is promoting buying your tobacco in a bag and then rolling your own cigarettes, because that way you get 100 cigarettes for 15 cents. And it's clear in almost every country in the world that if you raise the price of cigarettes, people smoke fewer cigarettes. So I think, our colleagues in the tobacco industry figured this out a long time ago, that the price is critical for tobacco use. Other common risk factors are obesity, and I like this picture by Ferdinand Botero because it shows both obese people, of which we have the highest rate in the United States, as well as people exercising, which is something that we need to encourage all people in our country and around the world to exercise, particularly those people who are obese, because we've learned even obese people can decrease their risk factors if they adopt regular exercise. So we've got tobacco is the most important, followed by obesity, inactivity, alcohol. These are all risk factors for which we can intervene, and which will decrease the risk of multiple diseases, including cancer, but not exclusively cancer. So the next signature theme for us is research on what I'm calling ecological niche cancers, because I haven't been able to find a better term for it, but it kind of refers to cancers that we don't know much about and don't see much of in the United States. So this includes, let's say, lung cancer among tin miners in China. We've been doing epidemiologic study in China for about 30 years now. We've got a big program studying esophageal cancer. Some of the highest rates in the world are in certain provinces in China. Again, we've been working there for more than 20 years. And our research network also includes some provinces in eastern Iran, which have very high incidence of esophageal cancer. And for some unknown reason, there's a very high incidence of esophageal cancer on the east coast of Africa. From South Africa all the way up to Somalia, we're seeing esophageal cancer in people who don't have the classical risk factors of smoking and alcohol use. Esophageal cancer occurring in very young individuals, people in their 20s and 30s, and we don't really know why. So again, our research networks include sites in South Africa and Kenya. We're looking at liver cancer in Thailand. As I mentioned, we're going to try to strengthen the work we're doing in Burkitt's lymphoma in the malaria belt. Looking at trying to better study oral cancer in India and other sites. Next theme for us, expanding global cancer research networks. We know that we can get more done if we work together. And so some examples here are the International Cancer Genome Consortium, which is an effort that set up to link the good work done in the United States that we call the Cancer Genome Atlas with other countries. And many countries around the world have joined this effort. And if you go to that website, you will see what cancers they propose to study. And they all agreed that they would make their data available on the web after the primary publication. Another example is that of our Children's Oncology group, which is a group that focuses on pediatric cancer, both biology as well as development of improved therapy. And they were founded with full partnership from sites in Canada. More recently, sites in Australia and New Zealand have joined. And they are, over the next 2 or 3 years, we hope that they're going to expand to Latin America as well. One of our adult cooperative groups, the Southwest Oncology Group, is also expanding its work in Latin America. They have done a very nice study with funding from the Gates Foundation, looking at treatment of Helicobacter infection. And then we also have an effort to see how we can better study EBV-associated neoplasia. We had a workshop focused on EBV in July 2012. We've since done a survey of potential sites for Burkitt's and EBV network in the malaria belt in Africa and Latin America. We recruited a team from the Fred Hutch at the University of Washington and their HIV vaccine network to help us assess the sites. They recommended 6 or 7 sites, 2 in Kenya, 1 in Malawi, 1 in Uganda, 2 in Brazil, and 1 in Guatemala for this research network. And we also want to expand our North American head and neck research groups into additional sites in East Asia to access more patients with nasopharyngeal cancer. So we see by expanding this research network, we can start to do some clinical trials of EBV vaccines. We can start to look at trials of more modern chemotherapy for Burkitt's. And we can start to do some clinical trials of combination chemotherapy with novel agents for Burkitt's and NPC, now that we're finally able to identify some novel molecular targets for EBV-associated neoplasia. Another example is something called the International Rare Cancers Initiative, and this was something that was started Actually, after a kind of a sidebar conversation with Prime Minister Gordon Brown of the UK and President Obama early in President Obama's first term, and they encouraged US and UK to get together to better study rare cancers, and so the partnership has grown a little bit. It's in the UK, it's their National Cancer Research Network and Cancer Research UK, USNCI, the European Organization for Research and Treatment of Cancer, and the French National Cancer Institute, and we're hoping to recruit some other groups around the world as well. And this is an effort to see if we can identify some rare tumors for which we need better treatment and for which we can actually identify some potential clinical trials that make sense. So the working groups here include salivary gland cancer, penile cancer, GYN sarcomas, ocular melanoma, thymoma, small bowel adenocarcinoma, and relapsed metastatic anal cancer. We did have a group that was trying to come up with something for fibrolamellar hepatocellular carcinoma, but they couldn't identify a clinical intervention, so I think they decided to start with a registry study just to understand the disease better. So the next topic, which I think may be of interest to our friends here at Duke, is how we can strengthen the work of NCI-designated cancer centers in global cancer research and control. So one of the things that we realized when we started this new Center for Global Health at NCI, that we really did not have a good handle on what our cancer centers were doing. Because cancer centers, we knew a number of them were very active globally, but they weren't using NCI dollars to do it. It wasn't part of the review criteria for the for cancer center applications or renewals. So we had no database of what the cancer centers are doing. And with the help of Dr. Linda Weiss, who runs our Cancer Centers program, we surveyed the cancer centers and were bowled over by all the activities that the cancer centers are doing. As I mentioned, we invited a number of the cancer centers to participate in our initial stakeholders meeting. And last year, we issued a competitive supplement program for cancer centers. It was a limited amount of money, but it was $200,000 total for 1 year. And we asked each cancer center to nominate their best idea. And we had more than 40 applications from the 65 cancer centers, and we made 15 awards. We hope to reissue that supplement program later this year. And we're also under discussions now with some of the other NIH institutes to see if we can come up with a plan that would, again, support cancer centers and their home universities to work together in specific countries or regions to address NCDs broadly, as well as cancers specifically. So that is still under development, but we're hoping that we can get some ongoing support for cancer centers and global health centers at U.S. universities to work together. We're also developing a global mapping program, because what we discovered was that there was no one database that you could go to find out who was working in Tanzania or who was working in Kenya. And so everybody agrees that we need such a database that would capture both grants and contracts, institutional twinning, individual projects, professional society activities. We're working now with a group at Harvard called Global Oncology. It's GO hyphen, and it's not GO Duke, but it's GO hyphen, or GO exclamation point, I should say. And we hope to have something that can be beta tested in about a month. But we'd certainly share that with you and ask you to help us make it better. One of the things that certainly I've been impressed with at Duke is the partnership that you all have with the global health programs across the universities. As I said, we're also trying to see how we can make sure that universities that are working in the same country and the same region actually talk to one another, not just U.S. universities, but also universities from Australia or UK or the Netherlands who happen to be working in the same area. And so the best example that we've seen so far is something called AMPATH, which was started by Indiana University, and it's focused on a partnership with the medical school at Moi University in Eldoret, Kenya. And they have put together a coalition of, I think, 8 universities and hospitals across the United States and Canada, all of whom work together in that one site. Later this spring, we're organizing a meeting in Kenya. Actually, I shouldn't say later this meeting. It's happening next week. Of bringing together all the U.S. universities and CDC and PEPFAR, as well as the representatives of the Ministry of Health and the NGOs and universities in Kenya that are thinking about cancer research, that are thinking about cancer control, to actually get in the same room for 3 days and focus on how they can work together. And so we think that this is an important, both something that is critical both for Kenya as well as perhaps a model that we can use in other countries on how to get people talking to one another. Another program that I know people in this room have looked at is the Fogarty International Center Global Health Program for Fellows and Scholars, which is a great program for people to do 1 or 2 years in sites in the developing world. And one of the things that we're working on with Fogarty is how to help bring those people along in their careers. We're still wrestling with that because we know we need to somehow strengthen the career track for global cancer research and global health. We've been able to do that in infectious diseases, to a certain degree in maternal child health, and we need to figure out how to do it for NCDs and cancer. The next theme I want to touch on is low-cost technology development. And there was a very nice article in the New England Journal last year that describes some of from the perspective of point-of-care technologies. And some other examples are handheld ultrasound, which is now widely available for obstetrical use, but it could potentially also be useful for evaluating breast masses. There's been an iPhone app developed to help screen children for retinoblastoma, and there's also this nice little device called a derm light, which is now widely available, that can be used to evaluate skin lesions. When we started to look at this field, however, it was clear that there were a number of programs sponsored by NIH in general and NCI in specific that supported the discovery and the development of devices. There were clearly companies there that were willing to commercialize good products, and certainly there were ministries of health and NGOs who were interested in buying products, but there was a gap in terms of who would actually support the multi-site validation of new products. And so we developed an RFA which well, actually, before I get to that, these are some of the mechanisms that we do have to support the initial development of low-cost technologies. This includes the NCI's IMAT program. Across NIH, we have the small business grants, the Innovation Research and Technology Transfer. There are also some bioengineering grants. And we do have an ongoing program announcement with our fellow NIH Institute, National Institute for Bioimaging and Bioengineering, and the India Department of Biotechnology. So the RFA that I said that came out last year was focused on how we could build teams to focus on low-cost technology in global health, but teams that would include expertise in global health, engineering, oncology, and business, because we wanted to make sure that if a product was effective, we could actually get it out the door and sold. So this is we built as what's called a two-phase cooperative agreement. We issued it last year, and we hope to issue it again this year and next year. And in the first phase, it's to demonstrate the clinical potential of a new technology, $500,000 per grant per year. We anticipate funding 6 grants this year, and we hope 6 next year, 6 the year after that. And then if in the phase 1 study that it actually worked, then we would have a $1 million grant per year to help do the validation study. And we've built in some specific milestones to go from that phase 1 to phase 2. In our first cycle, I think we got 97 applications, which we were very impressed with. The review has just happened, and we're putting together our funding plan now. And we hope to go to our Board of Scientific Advisors in September for permission to issue the second year of that RFA. Finally, I want to talk a little bit about building partnerships. I've touched on this all through my talk. We've certainly been working closely with our colleagues at National Institute for Allergy and Infectious Disease, National Heart, Lung, and Blood Institute, our friends at the Fogarty International Center. We've reached out to our colleagues in CDC, and CDC, I think, has made a commitment to improving the work and strengthening the work that they do in non-communicable diseases. A lot of their money is earmarked for infectious diseases, for maternal and child health, but they have identified 7 countries where they have big commitments of resources already, such as Kenya, such as Brazil, such as Colombia, where they would like to do more in terms of non-communicable diseases. Defense Department is another U.S. agency that we think can contribute to this. We're also reaching out to all the branches of the UN beyond WHO and their regional offices on this issue. I list there the International Narcotics Control Board because we have to have their buy-in for improving access to morphine globally, because they're the people who advise countries on whether morphine should be legal. And in too many countries in the world, morphine is not legal, and we can't get morphine for dying cancer patients. We're also working very closely with those other countries that are committed to global health and cancer research. And this is a short list here, but for example, we have a very close working relationship with the French National Cancer Institute. And they are very interested in the global health piece, particularly but not exclusively, but particularly in Francophone Africa. Similarly, Brazil is interested in how they can help in the Portuguese-speaking countries in Africa. South Africa Medical Research Council is strengthening its cancer research activities and have asked us to partner with them in some jointly funded RFAs. We also are working very closely with the Consortia of University Global Health Programs, and some of you may know we did organize a session last Friday, the day before the CUGH meeting, focused entirely on cancer. We've reached out to NGOs, to advocacy groups, professional societies such as ASCO and ASTRO, and my own professional society, the Society of GYN Oncologists, and International GYN Cancer Society, to help us, particularly with the cancer control planning and implementation. And finally, with the pharmaceutical, biotechnology, and device industries. Now, I've got 3 slides at the end that are I just wanted to give you a flavor of the meetings that we have been involved in and trying to help organize over the past 3 months. So I think it gives you a flavor of both where we're working and the breadth of activities that we have been involved with. So we had a meeting with the Middle East Cancer Consortium, and as part of the Turkish Cancer Week, we also organized a regional cancer control planning meeting in Turkey. We had a regional cancer control planning meeting for countries in Southeast Asia. We invited those countries that are actively thinking about cancer control planning to send 8 representatives, including civil society, including ministries of health. And for some countries that are just beginning to think about it, such as Laos and Papua New Guinea, we invited them to send one observer. We have had a meeting of our U.S. Latin America Cancer Research Network in Bethesda, trying to figure out how to build on the pilot study that we've done with them. We organized a workshop on cancer research and control for the Caribbean in partnership with CDC and the new Caribbean Public Health Agency. I'm going next week to the World Health Assembly and hope to get some cancer-specific business done there. We just finished a meeting with the Pan American Health Organization and CDC looking at HPV diagnostics. We invited all the companies that have HPV diagnostics to come to this meeting and present their data and see if we could twist their arms a little bit to bring their prices down so that we could actually use their products in public health screening programs. We had a joint meeting with PAHO and CDC on how to implement combined NCD health surveillance. I've got a team that's on its way now to Kenya for this National Cancer Research Control and Stakeholders meeting. And next month, we're doing an East Africa Regional Cancer Control Planning Forum in Zambia. At ASCO, we've got a number of satellite meetings set up on the Burkitt's lymphoma, on the head and neck cancer. We're also trying to meet with stakeholders from Burma and Vietnam. So I'd be happy to answer any questions if there's time. If not, I can talk at the cocktail reception. Thank you.
Thank you very much. I think if there are any pressing questions for Dr. Trimble. Yes.
Hi. Actually, I'm interested to see what do you think about the difference between American companies like GE and Philips. So we've been working on low-cost devices to add functional imaging to ultrasound, and we can do it very low cost. And actually, we were very interested to submit to that program. But then when we start talking with companies, large companies like GE and Philips, they were actually very adamant against us because they said, we put in the hospital for $250,000, $300,000 a diagnostic breast cancer ultrasound system, and you're trying to come to us with a $1,000 solution. We absolutely are not interested to collaborate. So how do you deal with this kind of, and I'm sure also for drug companies, the same thing. So how can NIH help university like us to do these low-cost devices without trying to get a partnership with large manufacturers who could actually distribute it afterwards?
Mm-hmm. Well, that's a great question, and I don't have an easy answer for that. I mean, we're trying to get companies to think about selling something in, I don't know, thousands of units or hundreds of thousands of units, and not in just hundreds of units, so that you make some money on each unit. But it is kind of a culture shift, and but on the other hand, we can't afford to deliver the price of American healthcare around the world. And even in the U.S., we're spending all this money, we don't have the outcomes that we would like. So I think we have to hope that we can either persuade the big companies or help grow some smaller companies that are willing to make and market low-cost devices.
Ted, can you tell us more about early career pathways for people interested in global oncology?
Well, certainly, I think in when one interviews for oncology training or residency training, it's important to find out whether the institution or the residency director and department chairman are supportive of doing rotations outside the U.S. And, I think, as I mentioned, the Fogarty Scholars and Fellows Program is a great way to get started. But it's that next step is a hard one because you need to find a job that will pay you a decent salary and health insurance, as well as give you hopefully find some time to set up a research program in the developing world. And we know it takes more time to do clinical research than basic research, and it takes more time to do clinical research outside the U.S. than do it in the U.S. So so you have to have a division director or department chairman who is supportive. And so we're trying to figure out how to both increase the number of RFAs, PAs that may help support some of that research, develop some infrastructure grants that would help support that young faculty member, just as and we have some examples from other disciplines, but it is a challenge. I mean, and we're trying to help both. We're trying to provide some career advice as we hear about people, as well as to brainstorm with the cancer center directors and department chairmen about how to do this, because we all want it, but right.
I think you're right to ask that question, and it applies both to the U.S. and also the developing countries, right? I mean, and I think what's good and NCI is doing wonderful things, but I think we can learn from now almost, 25, 30 years of HIV experience and what we're seeing at NIMH, NHLBI, well, I'm not sure where that's headed now, but certainly the K Award that we've seen with mental health has certainly brought in some people into the field. That is certainly helping if we can if there's support that could be made available for Ks for people coming right out of their training. We've seen that here, but I know other universities have seen that as well. That's one mechanism that seems to work, at least in mental health in particular. I think the big move in HIV, and John, you can talk about this maybe later in the panel, but was the D43 mechanism that were set up by the Fogarty Center in HIV. I don't know how many of you know this, but if you go back to 1990, John, maybe 85, I don't know when it started, but it's 90. So it's been available now for over 20 years. And if you look, this is the D43s support training grants. These are training grants that support investigators in low and middle income countries and they're institute to institute. I'm sure you know these. If you look at where the main HIV research has been done internationally in the last 20 years, there's a fascinating parallel with who got the early D43 grants. And I think it's a real story on how NIH has really moved where we had a crisis to get AIDS research done. And it was, to me, really interesting how the combination of the D43s, and then if you looked where the R21s and R01s went, they went to places that had the D43s. Now, I know D43s are not inexpensive, but I just wanted to mention, I think that's one of the real lessons we saw in HIV that I wish we could afford in cancer. And I don't know whether some of these, you would know better, whether some of these sites that have really gotten a lot of money from the D43s, in AIDS research could be used for cancer research, with some support.
Well, we have certainly been trying to study that. I mean, part of the challenge with the HIV-associated D43s is that they're all in Africa, and so yeah, so we don't have that basis in Southeast Asia or Central America where we'd also like to see activities.
From the successes you've had to date, what would you recommend? More working through governments? In the developing world, the governments really control most of the infrastructure and so on, versus NGOs in terms of, the best bang for the buck and just moving things forward.
Yeah. I would guess, as President Obama would say, all of the above or whatever. I mean, I think we have to get the governments to buy in. We have to get WHO Geneva. We have to get the regional WHO offices. We have to get the national governments. We have to get the state and provincial governments to support. Because if you're trying to come up with whether it's legislation for tobacco control or enforcement of that regulation or a cancer screening program, you have to have that government support. On the other hand, the NGOs can be much more flexible and can help fund the research that may be needed to guide or a government program. And so one of our challenges is to, let's say, we've been working with the Bill and Melinda Gates Foundation saying, hey, NCDs are important, can you help us with NCDs? And so we've made a little progress. I mean, they've been very supportive of vaccines and HPV vaccine rollout, but it is a question of getting the NGOs to start thinking about cancer and NCDs, as well as I said, making sure that all levels of government are supportive.
So in terms of low-cost instrumentation and obviously prevention is a very important goal for that instrumentation, but how about instruments that could gather large amounts of information for epidemiological studies, since it would be a very broad base for these clinics to be able to gather this information and be able to do the studies of the prevalence of diseases and early signs of the diseases that would be very easy to get in these kind of rural clinical environments.
Well, I think we desperately need better information on what is the burden of disease. And if you look at the work that Chris Murray and his team they use an incredible amount of modeling and some smoke and mirrors to come up with the figures that they generate, because there's very little hard data. So I think I think it'd be great to be able to use low-cost technology to have a better handle for who's got cancer and who's got diabetes and who's got high blood pressure, and what their risk factors are and what their environmental exposure has been. So yeah, I agree with you. I think it's it'd be great to have that, and certainly when we look at India and China and Africa, they're kind of cancer hotspots that we just don't understand, and we don't have any information on the environmental, good handle on the environmental exposure, a good handle on the other risk factors, a good handle on the molecular biology of the cancers that people are dying of.
Hi, I have a question about the escalating cost of a medical education for people who are interested in integrated fields of medicine, and I'm just wondering that, with the increased amount of medical information that exists, there's a lot of integration that's going on here. How can it be less of a financial burden for students in the United States to pursue these paths?
Good question. And I don't think I have necessarily a good answer. I mean, that's something that is beyond just global health. I mean, if you want people doing public health or doing primary care, then the cost of medical school affect the decisions as to what they go into and where they practice. So I agree with you, but I don't have any. Yeah, well, you're right. I mean, Nelson mentioned loan repayment program, which certainly we've seen. I think both for HIV as well as for reproductive health tracks. So maybe we need to think about that.
Hi, I have a question. First of all, thank you for a wonderful talk, Dr. Trimble. We really appreciate you coming. As one of the Global Health Fellows here at Duke, a recently transformed ID to oncology person, I worked in the lab of Tony Fauci for a couple of years at NIAID and loved it, and I had no problem obtaining funding. And now that I've explored this new avenue of NCD research, I'm having a lot of trouble thinking about what the next step is. After I get the Fogarty, where do I go? Do I have a K award available to me? So that being said, can you give us some advice and perhaps suggestions about where global oncology is headed from an NCI standpoint, and perhaps whether it would be more feasible to continue to collaborate with the HIV folks who have had so much, I guess, success in the past?
Yeah. Well, certainly, as Mike was saying, you know, the D43s have been very successful in research, in part because they had that training and infrastructure support. So certainly, you know, I wouldn't, or I would stay in touch with your infectious disease colleagues and mentors because, you know, they both have a strong track record, as well as the fact that we know at least 25% of cancers in the developing world are associated with chronic infection. So it's, so we're trying to see what we can do to, you know, increase the number of funding opportunities for people who want to do global cancer. But remember, there's that other avenue out there of global infectious diseases, many of which have relevance for cancer.
Thank you very much. We'll have an opportunity to continue this discussion in the panel a little later. So it's my pleasure to introduce the next speaker. Dr. Nestory Masalu was coming from Tanzania but could not get a visa. So we were fortunate to have a fellow Tanzanian fill in for him. So Dr. John Bartlett.
Super. So thank you, Nelson. As it turns out, I am a legal Tanzanian resident, so I'm really pleased to have this opportunity to talk with you some about cancer care in Tanzania and some of the relationships that Duke is building with partners in Tanzania. So I've had, although I'm an infectious diseases physician, I've had experiences with cancer care in Tanzania, both as a physician rounding on the medical wards, as well as a physician providing care in the HIV clinic. And so over the past 13 years, I've spent more than half my time living and working in Tanzania. And a recent focus from my own career has been on building capacity for cancer care research at the Kilimanjaro Christian Medical College that you see pictured here, as well as the Bugando Medical Center in Mwanza. So building upon the issues that Dr. Trimble has mentioned to us, we really see some striking trends in terms of global cancer. Here we're looking at the projections in terms of new diagnoses of cancer between 1975 and 2030. And if you compare that to, for example, my own specialty in HIV medicine, you can see that the numbers of new HIV infections are actually starting to decline. Then if you contrast that to global cancer rates in the United States and new diagnoses of cancer, you can see that the increase is much more modest. So it's really striking what's happening in terms of global cancer. Now, if we focus on projected cases by WHO region, you can see that there are striking increases in low and middle income countries. Let's focus first on Southeast Asia. You can see there's an increase over time. You can also see that there's a projected increase in Africa. Likely, these estimates are underestimated because of lack of diagnostic infrastructure and poor cancer registration. So what about the impact of cancer in Africa? It's now estimated, when I made this slide, it was estimated 650,000 new cases of cancer in Africa every year. It's now up to 800,000 new cases of cancer in Africa, with 510,000 deaths due to cancer. So this is really striking. That's an 80% mortality ratio. And as Dr. Trimble mentioned, more than a third of these cancers are preventable or treatable. There's probably no better example than the example of cervical cancer in East Africa. As you can see shown on the green side of the slide, the incident rates for cervical cancer in Eastern Africa are the highest in the world. What's really discouraging is that the mortality rates for cervical cancer, a totally preventable or treatable disease, are also the highest in the world. So Africa is facing some formidable challenges. So why is cancer increasing in low and middle income countries? Well, there are a number of potential reasons or explanations. First of all, the infectious causes may be becoming more prevalent. Secondly, we have aging populations. There may be immunosuppressive illnesses, such as HIV infection. There may be increased exposure to environmental toxins. Tobacco is promoted in the poorest countries in the world. It's really striking. When I drive in downtown Moshi, Tanzania, there's still tobacco billboards advertising cigarettes with the same kinds of themes that we saw here in the United States 40 years ago. There are also changing diets in low and middle income countries, and there may be some genetic susceptibilities to cancer. As Dr. Trimble mentioned, many of these cancers in Africa are virus-associated. Some may be due to the immune compromise associated with HIV infection. In addition, we see HPV causing cervical, oropharyngeal, conjunctival, and anal cancers. EBV is associated with different lymphomas, both Burkitt's and non-Hodgkin's lymphoma. HHV-8 associated with Kaposi sarcoma, and hepatitis B and C associated with liver cancer. So here we're looking at the proportion of total disease burden which could be preventable through reduction of environmental health risks. If we focus, and here we have to acknowledge that cancer represents a significant proportion of this disease burden. If you look at the scale, at the color scale, you can see that the darkest percentage is 30 to 40% of disease could be prevented through proven measures to decrease environmental health risk. You can see that the burden falls on the poorest countries of the world, especially in sub-Saharan Africa. Well, in resource-limited environments, we face a real challenge in terms of establishing the diagnosis of cancer. Establishing the diagnosis requires tissue examination. In low and middle income countries, it's difficult to find pathologists. Pathology is not considered a viable or a desirable career choice because you cannot make additional income. And as a consequence, it's difficult for it to be financially acceptable as a career pathway. So there are very few pathologists that are available globally. I think the country of Tanzania now, with 43 million people, has 12 pathologists. So it's an extreme challenge how we can meet the need for pathologists to diagnose cancer globally. Another significant issue is having satisfactory cancer registration. This is a critical component for cancer control and research on cancer. Skye Vanderberg, a rising fourth-year medical student at Duke, performed a systematic overview of cancer registries in Africa and presented this at the aortic meeting. What he identified was that there were a series of necessary components for successful registries. These included a well-defined population with referral patterns, well-trained, committed professionals, a standardized methodology, active data collection, histologic verification, and a complete data set. Now, when he applied these criteria to African cancer registries, he found that many of them were insufficient. There were some notable success stories in South Africa, Egypt, and Uganda, but most cancer registries fell short. So we really need to strengthen cancer registries in order to have successful cancer control and research efforts. In addition, there's significant shortages of treatment modalities. Here we're looking at the availability of radiation oncology around the world. And we know that the IAEA and some companies such as Varian are making substantial efforts to try and improve this situation. If we look at trends for medical oncologists, we see the same kind of pattern. The poorest countries of the world have relatively little cancer treatment services. So this is an important topic to address. And I'll have to say, as someone who spends quite a bit of time with Tanzanian medical students, up until the past several years, they haven't even thought about oncology as a career pathway. Increasingly, I think it's capturing the imagination of physicians, nurses, pharmacists, researchers, that they can have a career pathway in oncology. Well, what about the status of cancer care in Tanzania? The Ocean Road Cancer Institute was founded as a specialized facility for cancer care in Dar es Salaam, the largest city in Tanzania, in 1980. It was formally established as an institute in 1996 and was affiliated with the Muhimbili University College of Health and Allied Sciences. They see about 3,500 new patients per year with cancer. They have the capacity for radiation therapy and chemotherapy. But the challenge is that only 10% of Tanzanians diagnosed with cancer get to the single cancer treatment facility. And this is due to a whole series of obstacles, including problems with transportation, overwhelming the centralized cancer facility, and so as a consequence, it's really inadequate to meet the needs of the country. Now, there have been some recent expansions in Dar es Salaam, which I think are noteworthy. MUHAS has created a pediatric oncology program, which is delivering outstanding care. They are now offering specialty training in oncology with Masters of Medicine degrees. In addition, for those patients who are able to afford care in the private sector, the Aga Khan Hospital has established a cancer center. But in response to all this, the Ministry of Health in Tanzania has put together a plan to decentralize cancer care. So they have gone to the 4 referral hospitals in Tanzania with plans to open cancer centers in each one of them. The second cancer center that I will discuss is here in Mwanza at the southern tip of Lake Victoria, and this is at the Bugando Medical Center. In addition, they plan to open cancer centers in the Kilimanjaro region at the Kilimanjaro Christian Medical Center, and in the south in Mbeya at the Mbeya Medical Center. So there is a plan to try and decentralize cancer care and make it more acceptable to people in need. Now, this is a picture of the Bugando Medical Center. It's one of 4 referral hospitals in the country. It's a 600 to 700 bed facility. It is affiliated with the Catholic University of Health and Allied Sciences. This particular university has a strong relationship with Weill Cornell School of Medicine, and it's actually now called the Weill Bugando School of Medicine. They have begun to establish their cancer center, and here's a picture of the facility. Currently, they have 60 beds on their cancer ward, and it's been supported by strong relationships with Italy and the European Union. They have a new facility that just opened, and that's the building that you see here. And the funding for this came from the Ministry of Health in Tanzania, as well as with assistance from Italy and the European Union. They have a plan for a 120-bed cancer hospital, which will be here, supported by the Chinese government. So it's quite exciting to think about a dedicated facility for cancer care. They have quite a sophisticated radiation therapy facility. They are going to have 2 linear, or should currently have 2 linear accelerators, which came from Italy. They will also have a cobalt machine as a backup, and they plan to have brachytherapy. They have trained and retained a Tanzanian physicist, which can be a challenge in low and middle income countries. So they've made outstanding progress. They also have good pathology infrastructure. They currently have 2 pathologists at Bugando, and they're looking to expand this. They have a well-equipped laboratory, and they are developing telepathology capacity so that they can consult with partnering pathologists. Now here you see Nestory Masalu, and Nestory we were hoping would be with us here today, and as Nelson mentioned, he couldn't get his U.S. visa. He is the director of the Bugando Cancer Center. He's trained as a medical oncologist, and he trained in Italy for 5 years, so he had quite a substantial exposure to medical oncology in the north. He is building a fantastic team. He has insights with regard to the need for surgical oncologists, GYN oncologists, pediatric oncologists, pharmacists, nurses, etc. So he is assembling this team, and I think Nelson has identified him as a very attractive partner for the Duke Global Cancer Program moving forward. So I think we have some really outstanding opportunities to work together with Bugando and KUHAS. As I've just described to you, they have a wonderful cancer center. They are going to have new leadership in the medical center and at the university, and I know those leaders quite well. They are welcoming partnerships with Duke, and I think there are going to be great opportunities to build upon these relationships. We are hoping to place a Duke faculty member at Bugando, and we hope that this will be a conduit for other trainees to come to Bugando and to participate and to create this opportunity for a career pathway in oncology. We are coordinating these efforts with the Touch Foundation. This is a private philanthropic group which has been quite generous in their support for Bugando and KUHAS. They provide about 4 to 5 million USD per year in support. I was just up in New York City coordinating activities with this group. And then finally, through Nelson's leadership, it's all being coordinated through the Duke Global Cancer Program. So in 2010, we were fortunate to receive a D43 award from the National Cancer Institute, and the major focus of D43 awards is to build capacity for research, in this case, in HIV-associated malignancies. And so we faced some challenges at KCMC because there were no Tanzanian pathologists. We were entirely dependent on foreign pathologists who would come and donate their services for about 1 out of every 3 months. We had a hospital-based cancer registry that was inadequately maintained, no oncologists, isolated pockets of cancer care and research, mainly in cervical cancer screening and in Kaposi sarcoma. We did not have experienced nurses or pharmacists, and we had a very weak palliative care system. We did have some attributes in that we had really good laboratory infrastructure that had been built because of the HIV/AIDS-related research enterprise. And so we were able to build upon this to try and expand our services so that they would become more cancer-focused. Now, there are a number of challenges when you try and set up a laboratory in a lower middle-income country. There are challenges of reagent procurement. There are challenges of maintenance. There are challenges of quality control and quality assurance. And so building all this took a substantial amount of effort. One important lesson was that we needed 2 of everything. We needed 2 hematology analyzers, 2 chemistry analyzers, 2 flow cytometers, etc. Because if one goes down, you have to have a backup instrument. We also learned about participating in College of American Pathology proficiency testing. And now this laboratory goes through the same kind of proficiency testing as we would in the Duke University Medical Center laboratory. We also participated in the AIDS Clinical Trials Group, virology quality assurance testing, UK and NICWIS for flow cytometry, and the AIDS Clinical Trials Group immunology quality assurance testing. So it's a substantial undertaking to try and meet these international standards. So with the D43, one of the first things we tried to do was to address the shortage in terms of pathology expertise. And so we sent 3 candidates to McCary University to receive specialty training in pathology. 2 have finished last September and are returning to KCMC, and the 3rd will finish this September. And I really want to acknowledge the contributions of the pathology department here at Duke, who participated in a sandwich program and allowed these 3 trainees to come to Duke for 1 month per year to work in the department. And we are very actively pursuing opportunities for telepathology from KCMC with partners at Duke and other institutions, and in addition to create an immunohistochemistry laboratory. Now, it may seem incredible to some people in the audience that we wouldn't have immunohistochemistry, but I can tell you, if you go across the African continent, there are very few medical centers that have this capacity. Then we've had a number of other accomplishments. We've especially tried to focus on support for the cancer registry. We saw the cancer registry as a critical resource if we were going to build capacity for cancer research. And so we identified a very bright young Tanzanian physician, Michael Manishi, who came to UNC to receive his master's in public health with a focus in epidemiology. He further has linked with others at University of California, San Francisco. He had a summer fellowship in Lyon with IARC. He's had field placements with some of the most successful cancer registries in Africa. And so now he's returned to KCMC, and he is leading the effort to strengthen this registry. And what he's accomplished is quite notable. Here you look in the first 6 months since he returned to KCMC, and you can see over that 6-month period of time that there were 732 new diagnoses of cancer. So that's quite remarkable. And if you look at the histologic types of cancer that were being reported, not surprisingly, you can see that cervical cancer is at the top of the list, followed by prostate cancer and esophageal cancer in that East Africa belt that Dr. Trimble described. Michael has now embarked on a case control study of esophageal cancer in Tanzania, and he is getting ready to present his results. So maybe we will have some insights as to why esophageal cancer seems to be so common on the east coast of Africa. Now, in some other trainings, we had a gynecologist who wanted to specialize in gynecologic oncology. With Nelson's help, we were able to facilitate a South-South collaboration between KCMC and the Tata Medical Center in Kolkata. And so Dr. Indabawine was able to travel to Tata to receive specialized training in gynecologic oncology, and he's now returned to Bugando Hospital, where he's working as a gynecologic oncologist. Then we've had a number of other trainees go for training in palliative care, biostatistics, electronic medical records, etc., all specialties that are critically important to support the clinical research endeavor. We've also focused on training nurses in the Duke Cancer Institute. Very grateful that the Cancer Institute trained them and supported them, as well as a number of other opportunities, all facilitated by the D43 research training program. The D43 also supported a clinical oncology symposium at KCMC. Over time, we've managed to get some of the regional and international leaders to come and present at KCMC, and this has been critically important to share with young people that oncology is a viable career pathway. And if you're a young Tanzanian doctor, you should be excited about the opportunities because they're increasing tremendously. And in addition, over time, we had increased number of participants. You can see in this third year, we had 110 people come, including all the various schools around the campus, School of Medicine, School of Nursing, School of Physiotherapy, etc. We've also had some extraordinary opportunities to collaborate with partners within the continent. So the Uganda Cancer Institute in Jackson Orem has been tremendously helpful. Makerere University, Wits University, and University of Zambia. So we've had South-South collaborations with each of these entities. We have used our connections to UCSF quite successfully to try and have some standardization of the cancer registry. I'm really grateful, as I mentioned, to the pathology department here at Duke, and especially to Ann Nelson, who's probably known to some of you for her remarkable career in HIV-associated pathology. The radiology department here hosted trainees, and here you can see growing interest in global cancer at Duke with the new Cancer Institute director, Dr. Michael Kastan, and that really has come to fruition now in the collaboration that has resulted in the Duke Global Cancer Program. We've managed to connect with other programs such as the Medical Education Partnership Initiative and the Mentored Research Training Program. We have supported 3 pilot grants on cancer, and now we're looking towards the creation of a cancer center at KCMC, and we've engaged partners in Radiating Hope, which is a group of radiation oncologists who fundraise to help support efforts. Also in Minnesota, there is an entity called the Foundation for Cancer Care, and then Varian has been very interested in setting up an East African training facility at KCMC to train people in radiation therapy. So what are our ultimate goals? Our ultimate goals are to build capacity for prevention, clinical care, and research in cancer. We're using, in essence, a sibling model where Bugando Medical Center is the older sibling helping KCMC to develop capacity. We're really trying to link the oncology efforts to other KCMC Duke programs. And I think from the perspective of someone in global health, one thing that's critically important as we talk about global cancer is that it's not just oncology. There are huge social behavioral issues to be addressed, many different facets to addressing the opportunities and needs in global cancer. And I think we can help provide that perspective to the Duke Cancer Institute. Ultimately, we want to compete successfully for National Cancer Institute research support and create a sustainable and independent KCMC cancer program with Tanzanian leadership. So I'll stop there and thank you for your attention.
So in the interest of time, we'll take questions at the panel at the end of all the talks. So our third speaker will be Dr. Edmundo Mawad. I want you all to take really special attention because he has a cancer center like none other in the world. So it's really quite remarkable. Thank you.
This is good. Just a second. The last one. No, want to go to your last slide?
It is the last one.
Just a second. There we go.
Okay, and do it just like
this is the laser pointer. And use arrows to the sides.
Each one. Thank you very much for the invitation, Dr. Nelson. It was amazing to receive you in Barreto. Thank you very much for the great honor to be here. I'm going to show one hospital that we believe too much what we are doing. And I will start talking about general view of Barreto Cancer Hospital. This is my father-in-law. He founded 1967. And when he was finished his PhD in 50 and he came to the country area of Brazil, there was no cancer hospital in that period. And he made the philosophy that we work until today to see only the poor population, don't see private insurance or private patient, and to do the best treatment for all these patients. They like to be the VIP person. And we keep his philosophy. And I came from England in 1984. In 1988, Enrique, my brother-in-law, came with us, and he's an amazing businessman and a farmer, and helped us too much to doing our new institution. As you can see, this all Barretos is just a city around here. It's the middle of nowhere. All this dark point is city from Brazil that send patient to Barreto. Sorry, I think. And as you can see, Barreto here, you can see patients from all of Brazil coming to be treated here. And this is, as far as I know, I think it's the only hospital that I know in the world that the oncologists, the clinical oncologist, pathology, radiologist, all of them earn equal money. And this makes us to work very well on that way. And after 15 years of very difficulties, we had a government in Brazil, together with NCI, sent 1 million of letters to the Brazilian people asking about satisfaction of doctor, nursing, and all of. And between 7,000 hospitals, we are choosing the first one in satisfaction of the patient. And what we have done in this period, we do like free food. As you can see, we serve like 7,000 food for the patient and for the family during the morning, during the afternoon, for this patient, because they come very far away, they don't have money enough to eat, and to have free accommodation for them. And we have 1,100 beds outside of the hospital. And another very strong for us is to have ombudswoman and in each waiting room to see if the patient was well attended, and this ombudswoman is linked directly with our president. And we tried this on our palliative cancer patient. We try to do the best for them and what they wish before they die. For example, some, they want to get married before they die, and we do the wedding inside of the hospital. Some come from Amazonas, they want to see the river and to do fishing. We take them to do fishing. Some, they are so poor that they never had a birthday cake for them, and we do a birthday cake in their birthday and the singing. And for the employees, we have a daycare for 140 kids of the employees for free of charge. And for this is not interesting thing, it's ambulance driver, because they travel all night, 5-8 hours to bring the patient to Barretos and arrive over there, and they don't have place to live, to stay. And we made like a small hotel when they can sleep and eat and play cards. At the end of the day, they can pick up and their patient and go back again, and all are free of charge. And this was 6 years ago. Nowadays, we have like 13 or 14,000 new cancer cases. But if you compare with Gustave Roussy in France or Mayo Clinic in Rochester, even with Dana-Farber, that we do had more patient new cancer cases than all these institutions. And how another thing that we have done, we have been visiting this institution. For example, we used to travel, I and my brother-in-law and some 3 doctors visiting this American institution, saying what they are doing, talk with them, and trying to get what they have best. For example, like in MD Anderson, talk with John Mendelson. He asked us to change the way how to do it, not to stay like the radiotherapy, chemotherapy, and clinical oncologists, but all 3 together, like in head and neck cancer, and you have the same place, the head and neck surgeon, the clinical oncologist of head and neck, and the radiotherapy of head and neck, and nurse and dentist, all of them work in the same place. We are seeing what they are doing and try to get the best experience that you can do and bring it to Barretos. And in England, visiting Royal Marsden, we saw the importance to have our master and PhD degree in our institution. In France, we visit all this. In Netherlands was very interesting for us because we saw the breast cancer screening program. They control all the country. That's an amazing program. And they help us how to develop it in Barretos. We went to Italy. We went to visit Germany. In Berlin University, we visit a hospital over there outside of Berlin when they take care of home care of this patient. And because in Berlin they are very lonely people and they need to have bring their dogs before dying, and we got some experience over there. And Karolinska Institute and Gothenburg University. In Japan, we got a building from cancer screening from the idea of the National Cancer Institute in Japan. And we visit all this hospital in this country too. And how is Barretos now? This is our main hospital. It's 120,000 square feet. And this hospital, we have outside of this hospital, this house that you can make this patient to stay over there. This is some internal view of the hospital. We have a second cancer hospital in Barretos too. It's for palliative cancer care. And this is some internal view of this hospital. We have a third cancer hospital in Barretos just for children. This one is a newest one. It's amazing. We got architect from Brazil, but the interior design is from a person from Florida, from USA. She went over there, and she designed was amazing. Like, for example, this room, it's an amazing room because the kids, it's for palliative cancer. For palliative cancer care, the kids, they can look at the roof before they die, and the roof can change every 30 minutes in mountain, sea, everything, because he can move from his room. And we keep all the family inside, brother and sisters, inside of this room. There is some internal view of this hospital. It's amazing, these new children. And this is our 4th cancer hospital in the state of São Paulo. The idea is to have the patient not travel very far to Barretos, this hospital close to Mato Grosso do Sul, another state. And we try to, it's belong to us, all the employees work for us, and the doctor, everything belong to us. There are some internal view, this panel, for to be more funny, and the hospital. This is another big problem, because in Amazonas, they don't have in this state a big cancer hospital, and they used to travel, take 2 to 3 days to come to Barretos. We decided to have, there was a university hospital over there, and we got 2,000 square meters for them, and we are trying to have a piece of our hospital, just a small piece, but we can hold a lot of cancer cases, and you can do a palliative care for them over there. And it's and you found some of difficulty that you said, because it's difficult for the doctors who wants to go to Amazonas to work over there, and difficult to stay over there, and we are having some difficulty too. And this is another building. This is amazing. It's the biggest building for laparoscopic surgery in the world. It's they have one in France, one in Taiwan, and this one in Brazil, in Barretos, is to use animal, to use pig for training. And it's we have 21 operating room, like you are seeing, for doctors. It's amazing place. You have like 850 professionals all over the world who does the training in Europe and in China and in Barretos. They come almost every weekend to do this course to the doctors. And we have trained more than 2,000 doctors and nurses. This is just for, it's not oncology hospital, day hospital. It's just for us to do the administration because the government asked us to do that. But it's not our main interest, non-oncology. And we take care of this another building too, just for non-oncology patients, but just to help the government in Barretos. Both are in Barretos. And this is a School of Medicine in Barretos that belongs part to us. And it's a new one, brand new, and we try to develop doctors in the same mission and same concept that we do at the hospital. In summary, we have 5 cancer hospitals. We see, it's amazing, 3,000 cancer patients per day, because we never leave the patient. When he finishes his treatment, once a year he has to come back to Barretos, because unfortunately we don't have clinical oncologists all over Brazil to be treated, to be seeing this patient in a good way. We prefer them to come back to Barretos. And we have more than 700,000 patients per year that come to Barretos. And as I told you, 100% of our patients, they don't have to pay anything at all. They belong to national public health system. And for example, in radiotherapy, we see around 400 patients with cancer per day. I start at 6 a.m., finish 11 p.m., or during all night. And in Teaching Research Institute, what we have done, we make this network that was very important for us to have a good network for us to keep growing. And for example, with MD Anderson, we had this network for the last 5 years. We are like sister institution, and every year we have a meeting. For example, in August, now is coming 17 faculty members from MD Anderson in different fields to spend 3 days in Barretos, and they see what they are doing in each department, and they see the possibility how we can develop research together. St. Jude's just joined to us 1 year, I think 1 or 1.5 years ago, and we are doing the same, a lot of projects together. And UCLA came, like I went over there in October or November, and we signed the MOU recently, and now they are going to have a meeting in November. It's coming. They are interested in radiation department. They don't have international activities like Duke, and the radiation department are main interest. In France, we have this network with ERCAD in laparoscopic surgery, and in Netherlands in breast cancer screening. It's a big area in Barreto screening. We have some papers with MD Anderson, and I found one with Duke. I think they've done 3 years ago in, I think, medulloblastoma genomic analysis that came to Johns Hopkins and Duke. They sent tissue to here. And the head of our lab of molecular diagnostic we brought from Europe, and he has done a lot of certification, quality control from Europe, and he used the control of the exam from the European quality. As you are saying, it's important, very important to have a quality in this country. And or from the UK, they use quality control of these 2 institutions, 2 countries. And this is something that interests, I think, all of the world. You have 130,000 tissue samples, and you are using just 1% of this tissue sample. And I think it's pity that I show rare tumor and some other tumor not to use the sample to do research. And as Nelson visited, we have a lot to do in cancer research. There is a lot of things to do. And this is a new building that just of the Ministry of Health came to Barreto to open it. It's a building, that clinical research unit, that we are very interested to work with Duke, because we made this building to do phase 1, phase 2, phase 3 studies, and we have everything brand new. We have quite a good experience, but I think what I've heard about Duke, it's amazing that we are doing in this field, and I hope we can work with Renato and Nelson, all of these people in this area. Prevention is a big, big business in our institution. This is the building, the first building that we have Institute for Cancer Prevention, for cancer screening. And this is done with the Avon. Avon Foundation, it's an American company. They have in Brazil too. They have 1,500,000 people selling their product. And they gave the part of this money to us to do this building just for cancer screening. And we won the biggest project from Avon last year. In 8 years of Avon, this was the first project, the biggest project they had. And after that, we saw that the cancer screening, we should go to other areas, not stay just in Barretos. And they gave this hospital to us. We changed for cancer screening hospital in the other area of state of São Paulo to do the same what we are doing in Barretos region. And this is a country like you saw in Africa, but in state of Bahia, it's very poor state. They have a lot of poor people. They have some area there is no pavimented road. For example, we have over there, we had this building and the mobile unit. This mobile unit is amazing because they don't have, it's analogic equipment here, and they don't have water to bring. They have to bring water like that in this kind of transport to bring water for the equipment. But we have all this work over there, and now they even call us 2 weeks ago. They want to do this building like the Barretos, to do a building in this city. And in Amazonas, that is, it's look like maybe to Africa. And what we are doing in Amazonas. We have a mobile unit. That's incredible. This is our mobile unit. This mobile unit was done in Brazil. We have a place for blood collection and rectal examination to do prostate cancer screening. We have another place for do pap smear collection, and another place there is operating room. And in this place you can see the skin lesion and treat the skin lesion, most of the skin lesion. And in Amazonas, they don't have roads. You have to cross this mobile unit through the river. It's amazing job what our doctor and nurses are doing over there. And when they go, because before they go, the city has to sign a contract with us that they are taking the people, if they have abnormal exam, to Bartlett or to other place to be seen. And they are received like a king. They are do a lot of things for them because they don't have medical oncologists to receive over there, and they go all this there. And as you can see, this group are made by always one doctor, one nurse, and 3 assistant nurses. You spend 1 month traveling in these cities. After 1 month, another group of come another doctor, another nurse, 3 assistant nurses. They work during 8 months in Amazonia, and because during 4 months there is too much raining over there, the mobile unit can't go in this place. And I got some data from 2013, for example. They saw around 4,000 skin patients, and they get more than 500 skin cancer, and 90% can be treated inside of this mobile unit. And now we are doing, I was telling, teledermatology, and we are going to get much more cases before we go with our mobile unit. This is what we are doing for prostate cancer screening in Amazonas. And in Amazon, we see around 6,000 cervical cancer screening women doing this. And talk very strong for them that they have to sign the paper to send it to Bartlett or to other place. We lost just only % of lost follow-up after third sanitary letter for 3 times. If they don't come, just 11% lost follow-up. And now we are going to explain a very good experience that we got from Netherlands, from Europe. It's organized breast cancer screening. I don't know, I think USA doesn't work with organized breast cancer screening. I think it's a good experience. I'm going to talk first with cervical cancer screening. We got it from Finland. They are one of the best ones in the world in cervical cancer screening. What we have done, as I am responsible for all the 19 cities around the Bartlett when we start for cervical cancer screening, all the pap smear from the public health system come to Bartlett. And we start to offer them to do exam in the mobile unit or in our building, or they can do in their own city. But we bring their nurses to our hospital to be trained how to collect pap smear in a good way. And after that, we can go to their cities. And now we are with 62% of women of our region are doing exam, or in our building, or in our mobile unit. The idea is to, in these small cities, we don't need to have a big program over there. If you can go and do it for them, to have a good doctor, a good nurse, and to do everything for them, is much better, in my view. And in that case, we are following like 50,000 women now, and we send a letter to them when the results are normal, and we send that they have to repeat 1 year, and 1 month before 1 year, we send a second letter, say, look, it's going to become 1 year, you have to repeat your exam, and if they don't come, we send another letter, and we try to get as much as possible all the women that we start doing the exam. And it's amazing because we have clinical stage 0, 85% of women diagnosed in our region, and in clinical stage 1, 8%. In that case, 93% of the cancer cases are cured in Barrett's region. And in breast cancer screening, it's a bigger program. This we get from Netherlands. We are responsible for, I think, more than 100 cities around 3 different regions, state of São Paulo, and this one in Bahia. We have one building, one on mobile units. And what we have done with these women? We offer mammography screening in the mobile unit or in the fixed unit for every woman in 4 to 69 years old. And we've done almost 8,000 screening mammography. We got 305 cancer cases, and this is very interesting because we got to the stage 66% in all women. But if you follow like Europe, that you can use only asymptomatic women, we get 81% of women in our region has early breast cancer and can be cured. 81%, it's an amazing number. When I'd say organized breast cancer screening, I mean that I'm responsible for everything. I'm responsible for offer the exam, I'm responsible to repeat the exam, I'm responsible to do ultrasound, I'm responsible to offer the treatment, everything we're responsible for. And this is our mobile unit. I think this is the newest one. This is made in Barrett's now. This is the waiting room before she does the mammography. And in this mobile unit, you have 2 digital mammography inside. I think is the first in the world with 2 digital equipment inside. I haven't ever seen anywhere. And it's working for, I think, 5 or 6 months and working quite well. And because it's nice if you have offer for the poor women, a nice place to do it and treat her very well, she will come. We have now 9 mobile units. And this is another thing that we have done. For example, we couldn't read all the mammogram exam. This is a big problem, for example, in the Netherlands too, or in Europe. You don't have enough breast radiologists to read it. And we made a central report in other cities, and we have 7 breast radiologists who received the exam from the mobile units for this central data, and they can get the result and send it back to them by internet result. And this is what we got from Netherlands. They have a very big program. I think they see around 2 million women with screening. And they have 8 regions in Netherlands. They control this 8 region. And after visiting Barrett's 5 years ago, they decided to come to Barrett's, and we took them, and now they control 8 regions of Netherlands and Barrett's region. It was amazing because we send our doctor to be trained over there, our nurse, physics, radiographer, and they come once a year to spend a week in Barrett's and to improve our program. This is when they are coming. They generally come. This is a breast radiologist. She is a breast pathologist. She is a physicist. He is a radiographer. She is, I think, works with quality control. And they spend a week working Barrett's and to get the same pattern as Netherlands. And we are very proud to have this partnership, and they are doing a very good work with us. And after we got this experience, we saw that we shouldn't stay with this knowledge just for our region. And we opened a mammography school with these people to use the same training as these people from Netherlands, here at LRCB. And America Amigas, it's one non-profit organization who the president is the wife of USA ambassador in Brazil. And they give mammography to several places in Brazil. And what they decide to do, before they give the mammography equipment, they send the radiographer and the physicists to be trained in Barrett's. And they even are doing the same. And GE chose Barrett's and put the equipment over there just for training these people. And like they said, we're the best Latin America show site of GE for training. And And this is the physics and radiography. I think maybe in Africa, you may have the same problem. They don't have a good quality training, and it's important for them to come and to have a training, a very good training, and they are coming to have all the states. And one of these projects is together now with Unifesp from Marinha, from Navy. They send the people to be trained in Bartlett because they have a mammograph inside of ship. And I'll tell what she told me. I don't know if it's true. She said the first mammograph equipment they put in America, there was not this equipment included in USA. Is equipment to do mammography that women, before doing the exam, she can choose when she was doing the mammography what she wants to see. If she wants to see like flowers or sea, and she can choose what sound she's going to like and what smell is going to be in this room. She said because there is a lot of problem in this Latin America or Africa because they feel a lot of pain during the exam. They are not well prepared. In that case, it's good to have equipment like that. And I don't know if they told this first one. I don't know. And how then all that if you don't have money govern in Brazil, national public health system pay very badly for the cancer and for general. And 35% of population has private insurance. And we had a partnership with government. They put the federal government, state, and the city put some money to help us. But most of what we've done is in partnership with the civil society. I think it's look like visiting America the first time 15 years ago in MD Anderson. We start to see what the civil society now. They receive, I think, $200 million, MD Anderson. And we have like 50 famous singers in Brazil. They do a show in São Paulo and Rio, and they send the money to us to help our institution. In the last 20 years, we are receiving, these are quite famous singers. And after that, they give on music to us. And in this music, we make a CD and DVD, and the Post Office of Brazil, and the Post Office and the Avon has 1.5 million people sell their products, sell our CD and DVD for us. And this is another good example. We have a magazine, and the poor people keep always helping us. They do $1, $2, but they keep giving the money to us because they feel very proud to be in the hospital, to be well assisted. And another way was amazing, not months, each year, but John Mendelson from MD Anderson could believe we received 206 tons of food donation per year. Some seeds and rice, another one sent beans, and one rich man sent his abattoir sent 10 tons of meat per month to us. In that case, we don't have to buy almost any food at all to keep our institution. And this all they've done because how we treat them, how we've been treated. We treat them like the most important people, the patient, the family. And this is interesting way that we found. For example, it's difficult for the poor patient give some money, but he wants to help what he receives in our institution. One patient went to Amazonas, and he got one cattle from Nelson, another from you, another one from another one. When he got 150 cattle, he make an auction and send money to us. And it get a lot of money from this kind. Every year we start with 10, now have, I think they'll have more than 300 auctions every year, helping us to keep our hospital the same way, the same mission. This is another way that we got money for not the sugarcane company. They can make energy, and they have some. They can give some energy to us because they don't use all this energy that they have, and we receive like this. I don't know how I should say, but it's like we are using 30% of our energy are paid by this sugarcane company. We don't have to pay anything at all. There are several sugar canes that send it to us, helping. This is a new, I was talking, it's new. We have, it's the Brazilian government have done it 4 or 5 months ago. You can give 1% of your tax, give it to one cancer hospital, and you don't have to pay to the government. And it's amazing, because if you have a good credibility institution, you can get this 1% of this institution. And when we start this year, no one could believe that we could get so much money. And we receive a lot of donation from this bank, and Volkswagen, Nestlé from Switzerland. This is from Norway, not Norway, no, I think it's from Sweden. This is biggest orange juice company, and they give 1%, one part of them 1% to us, and help us to pay our deficit. And the next 5 years, what do I think our next plan for next 5 years? We finish with the first one, is to have our own factory for doing our mobile unit, because we used to send to do mobile unit in São Paulo. It takes 5-6 months to do one mobile unit for us. And then we decided to have our own factory in Barretos, and we send one of our docs that work on that to USA, to GE, to see where GE does the mobile unit, and to Lorad, and then we send to him to Europe, and he went to Netherlands. And in Netherlands they have one factory called Lambu, they have a factory who does mobile units for Europe, and they have a second factory in Moscow and third one in Dubai, and they opened that fourth factory with us in Barretos. It's amazing, because they can do one mobile unit. They said in 4 mobile units per month, 1 per week. Nowadays you are taking 2 months to do one, but with their equipment, and they say you can do more quickly. And this is another very ambitious plan. We have 3 Institute of Cancer Prevention. As the Brazilian government is not so fast, it's slow, a lot of bureaucracy, and the university in Brazil is, I think, is a little bit far away from what's going on the health. We decide to open 5 new Institute of Cancer Prevention all over Brazil. And this 5 is going to be most, as you can see, in direction of Amazonas, or in this direction. And each center of that is going to have 1 center and 1 mobile unit. Like, for example, in this center, like in Barretos, we offer a mammography or pap smear or other exam. And in the same place, following the European guideline for mammography screening or cervical scan screening, we offer diagnostic in the same institution. If there is abnormal exam, they can do the biopsy. And the new thing that we are doing now, new institute, is to have an operating room, day hospital. In that case, tumorectomy, conization can be done in the same institution, and they are going to send just advanced case to Barreto. I think it's going to be a good idea. You want to have 5 new institutes of that around Brazil. And we finished the first one 1 month ago, something like that, in Campo Grande. It's all of them you like. It's not like that. It's brand new. It's a good thing to do, and this is a place when you want. The second one, they said, is going to be ready until the end of the year. I hope so. And our idea is to have 5 in the next 5 years. We are almost finished 2. And our next dream, that this is impartial, is to have our own cancer hospital in Amazonia. We have indigenous people with cancer. Some kids are coming to Barretos Cancer Hospital, children, they don't speak Portuguese, and they have apparently some molecular profile differently. They have chemotherapy, they don't lost hair. And we want to have indigenous air international just for cancer. And Our architect is talking with some people, some doctors that work in UniFest, that work with Indians to see how they think, how it can be done. And in this hospital, we want to have research, prevention institute, and palliative care for all the Amazonas area, to have a big, nice institution over there. And someone gave to us 7,000 square meters 8 months ago, and this month we are going to start to this new project, at least part of them, with donation from this institution. This is going to be the hospital how we would like in Amazonas. And thank you very much for the invitation. It's thank you again. I hope we can do something together too. Thank you.
So why don't we take a 15-minute break, and then we'll come back at 3:05. Thank you. Why don't we plan to get started again so we can stay on time? I could invite you all to take your seats. So it's a great pleasure to invite Dr. Jian Zhou from Fudan University, who is the head of the Liver Cancer Institute. He's going to tell us about liver cancer care and prevention and diagnosis in China. Thank you.
Dear Professor Chao, and dear ladies and gentlemen, first of all, I would like to thank Professor Chao to invite me to be here and share the experience to tackling the slow motion disaster cancer. Today my topic is diagnosis and treatment for liver cancer in China. I'm from Liver Cancer Institute, Zhongshan Hospital, affiliated to Fudan University, located in Shanghai, China. Liver cancer is the sixth most frequently diagnosed cancer and the third most frequent cause of cancer death. And half of these cases and deaths occur in China. So China accounts for 55% of total liver cancer deaths in the world, nearly 300,000 cancer death in China. Right? China has the highest incidence of liver cancer in the world. Why so many people? Because nearly 10% of normal people will have hepatitis B virus carrier. So many people, more than 100 million people have hepatitis B virus carrier. So many people have hepatitis B virus, and will develop 50% will develop chronic hepatitis, and then 20% will develop cirrhosis, and finally 1 to 3% of cirrhosis people will develop liver cancer. So more than 80% of liver cancer in China, mainland China, have hepatitis B background, and the 90% of liver cancer, the pathology type is hepatocellular carcinoma. So, but when the liver cancer diagnosis, only 20 patients are found in early stage. That means most of advanced liver cancer are unresectable. So liver cancer is the second most, is very common in China. Is not as common as here in the States. Liver cancer is the second most frequently diagnosed cancer, and also the second cancer killer in male, and the fifth diagnosed cancer and third cancer killer in female. Our Liver Cancer Institute of Fudan University at the very beginning was a cancer study group. Then we focused on liver cancer. At that time, only a small liver cancer study group, and then developed to the liver cancer unit in 1988, developed as Liver Cancer Institute. This institute includes 3 parts: liver surgery department. We have 110 beds. I'm the director of liver surgery department. And we also have internal medicine department who do transarterial chemoembolization and do some tumor ablation like radiofrequency therapy, like so on and so on, and also radiotherapy. And we also have a 1 floor for the laboratory research. Now, this is our staff members. We have nearly 80 staff members, include physicians, surgeons, and around 10 staff members for the research. And this is a new building. We will move to the end of this year. And our hospital is famous for liver and heart. We have 2 buildings. One is liver here, one is the heart. All the liver is for liver cancer. Liver cancer we can call the liver cancer building because laboratory, physician, and surgeons we work here at the end of this year. And our beds were impaired 2 times to our surgery department, where surgery department will expand to where have 200 around 40 beds. So during the more than 40 years, we have experience for around 20,000 liver cancer resection and more than 1,200 liver transplantation and 10,000 for chemoembolization, and the radiofrequency also include personal insular injection for the tumor ablation. So every year, recently, we have more than 2,000 operations for liver cancer resection. This is the second largest in the world. The largest is also in the Shanghai, another hospital. So overall survival, the 5-year overall survival of the liver cancer patients after undergoing liver resection, the total 5-year survival is around 45%, and 10-year survival around 25%. And also include this liver cancer include the early stage and also advanced tumors. And this is very improved a lot as compared to the decades ago. Today, my talk will include 4 themes. The first is early diagnosis and early treatment. In China, we combine alpha-fetoprotein, one the tumor marker for hepatocellular carcinoma, liver cancer, and the ultrasound graph as a screening test for liver cancer in China. And after combining using alpha-fetoprotein, 1 milliliter of blood, and combined with ultrasound, we can detect 92% of the liver cancer. If we use alpha-fetoprotein alone, only 70% is positive, and use ultrasound alone, only 84% can detect the liver cancer. So the combined test may be the best choice for primary liver cancer screening in China. Actually, in China, this is a routine screening test for liver cancer. In 1970s, my teacher, Professor Tang, reported firstly in the world for the diagnosis of subclinical liver cancer, means without clinical symptoms. Usually, if liver cancer have clinical symptoms, also means to advanced liver cancer is unresectable. So the professor used also alpha-fetoprotein and ultrasound, found hundreds cases liver cancer patients with subclinic liver cancer, and also after liver cancer resection, the 5-year overall survival as high as 70%. This is very, very high as compared with as non-resectable liver cancers. So at that time, he won the gold medal in the States, and also he write a book named Subclinical Hepatocellular Carcinoma. And the preface of this book was written by Hans Poppel, who is a world-famous pathologist. He said this concept represents the major progress in the understanding and particularly the management of liver cancer, hepatocellular carcinoma. So because of the achievement in the early diagnosis and resection of small liver cancer, we are invited to write the liver cancer chapter in 3 editions of UICC Manual of Clinical Oncology. Until the last July, in our Liver Cancer Institute, we have more than 3,000 patients survived more than 5 years after liver cancer resection, and more than 800 liver cancer patients survived more than 10 years. More than 60% of the long-term survival came from small liver cancer. Small liver cancer means the tumor size, the diameter is less than 5 centimeters, or 2 nodules. Total, the diameter is less than 5 centimeters. These 2 gentlemen and 1 lady survived more than 30 years. At that time, after liver cancer resection, this lady delivered a child. This child now is an undergraduate student. So many patients can even survive 70 years. This lady, 47 years after liver cancer resection, he underwent liver cancer resection in November of 1967, when I was born at that year. So this lady also still alive without disease. So although techniques improved, such as MRI, if combined with the new developed contrast, can further improve the detection rate of small liver cancer. This is my patient. Is only I do liver cancer resection. The liver cancer only 0.5 centimeter in diameter. So, however, the most of patients when diagnosed are advanced. So new marks for liver cancer for early diagnosis are still very important. Recently, literature report a lot of tumor markers such as osteopontin, microRNA plasma, but few are applied in the clinical use. Recently, my team established a diagnostic signature with 7 plasma microRNA model. This model can diagnose even very early stage, the tumor less than 2 centimeters in diameter, BCL0 staging with a sensitive and specificity more than 80%. Even for those patients with alpha-fetoprotein negative, also has higher sensitive and specificity. These results were published in Journal of Clinical Oncology, and this journal also published an editorial said the microRNA panel had sufficient accuracy to discriminate patients with hepatocellular carcinoma from health controls, patients with chronic hepatitis B, and patients with liver cirrhosis. And it has the potential to be used for the stage detection of hepatocellular carcinoma. We try to produce this product to be used in the clinic. Maybe 2 years later, we will maybe try to launch it in the clinic use. Actually, the early diagnosis and resection of small liver cancer have changed the clinical pattern of liver cancer in China. In 1970s, when diagnosed, more than half, 50% are advanced hepatocellular carcinoma. But recently, in recent 10 years, in our hospital, only less than 20% of the liver cancer patients are advanced liver cancer. So at that time, only 6% are resectable, can have the operation. But recently, those patients who came our hospital, nearly 50% can be resectable. China has introduced the hepatitis B vaccine program into national infant immunization schedules, just as Professor Trimble introduced. China government have paid very much potential for this. In Taiwan, the hepatitis B vaccination program were launched early in 1980s, and after the vaccination program, the hepatitis B virus carrier has decreased to 1% from the 10 to 17%, and also the liver cancer incidence rate decreased a lot. So hope maybe 20 years or 30 years later, in mainland of China, the liver cancer incidence will decrease. The second theme of my talk is algorithm of treatment for liver cancer. So we need to consider the treatment for liver cancer patients. We should consider the patient performance status and liver function and the tumor staging. And this is a China guideline launched in 2011. I'm one of the main writers of this guidelines. So we need to consider the performance status, liver function, and the tumor characteristic include if the liver cancer have extrahepatic spread or vascular invasion, tumor number and size. So lots of according to the 3 parts of these areas, we can decide if the patient can receive resection or ablation or TACE or radiotherapy or targeted therapy or even palliative care or supportive care, or even some patients very late stage can receive liver transplantation. So China, the guideline for liver cancer is quite different from the abroad, because in China the operation indications are more expanded than as compared to the abroad, and improve the diversity of the liver cancer with vascular invasion in selecting treatment methods, and also we add radiotherapy as a adjuvant routine for the liver cancer for some patients with high risk for recurrence and metastasis. And we have expanded the indication, the criteria for liver transplantation is quite different from the United States and the Western countries. We found this, our guidelines is quite suitable for China's national conditions, but also we need to be improved based on evidence-based medicine. Like BCLC B staging, but in the BCLC guidelines, in the Western guidelines, only do, if liver cancer with BCLC B staging, only do TACE, means transarterial chemoembolization. But in some selected patients, we also can do operation. We do randomized clinical trial and found resection provided better overall survival than TACE in China. So TACE is the only choice, but TACE is the only choice in BCLC staging for stage B in Western guidelines. And I just said, liver cancer criteria for liver transplantation is quite different to the other countries, because I know even in mainland or even in Taiwan and Hong Kong, they also use Milan criteria. But we've established our Shanghai Fudan criteria. We expanded the tumor, the solid lesion from 5 centimeters to 9 centimeters, and no more than 3 with the largest less than 5 centimeters, or multiple tumor, the total diameter less than 9 centimeters. And we found that if even we expanded the criteria, we found the overall survival is as same as the Milan criteria. We begin our liver transplantation in 2001. This is the first case patient for in our liver transplantation program. This patient suffered from liver cancer with 7 centimeters in diameter for the tumor, and this patient have disease-free survival more than 13 years. And also, this is the first to add a living donor liver transplantation, and with a patient with cirrhosis with multiple tumor, and also the patient survived more than 12 years. And this donor from his father, and the father a little bit fat, although a little bit fat. The patient is very lucky. So radiotherapy is not 10 or 20 years ago, the radiotherapy, they said the literature reported is not sensitive for liver cancer. But our experiment and results show that some patients also can sensitive to radiotherapy. And we really found in our clinic in some patients with lymph node metastasis or even inferior venous cavernous tumor thrombus in the IVC can also do radiotherapy, can improve the survival. And this patient even have neck metastasis in the lymph node after tomo radiotherapy, even the patient with disease-free survival for more than 3 years. And we also use some Chinese herbs as the adjuvant for this is our carrot. We also find some Chinese herb can inhibit the MMP2 and the VEGF, the expression, and can inhibit the tumor growth and the lung metastasis in the experimental studies, and now also used in the clinic. And we really found some extract of herbs can have the result of inhibition tumors. The third theme is comprehensive treatment, because if we found the effective mode is not the single treatment. We found the test plus percutaneous ethylene injection is better than the single use, and the test plus radiotherapy is better than single use. And if we do liver tumor resection plus targeted therapy like sorafenib is better than the single use, and the chemotherapy can plus interferon can be better than single use. And we also in the clinic we also need to pay attention to the biologic treatment of the liver cancer patients. When the tumor, I just said, most of patients are advanced, only 20% can be resectable. So most of patients is unresectable. We can downstage the tumor from the unresectable to resectable. We can use surgical treatment or use non-surgical treatment to downstage liver cancer. Surgical treatment, we can use hepatic artery ligation to shrink, to block the blood supply of the liver cancer. And also we can do intraoperative cryosurgery or plus radiofrequency plus microwave ablation or even ethylene injection. And also post-operation we can combine it with internal or external radiation. The non-surgical treatment, most of our tests or plus radiofrequency intratumoral ethylene injection or plus Lapado 19 E3Bs and usually multimodality treatment. However, only less than 20% of liver cancer have the opportunities to receive resection for downstaging. This patient, after 3 times after test, and find the tumor size shrink very sharply, and later we perform the surgery, we can find most of the liver cancer have necrosis, but at the peripheral, we can still find some tumor cells alive, so the tumor resection is necessary. And this gentleman have survived more than 15 years after the very big tumor. After with radiotherapy, the tumor shrink, and then we can start a reduction, liver cancer resection. So actually, in the early 1970s, we started to downstage the liver cancer at that time, and also recently we found the survival rate of different period of liver cancer patient after sequential resection. The 5-year survival is high as 50% for unresected liver cancer. So it's a quite good measure. So because of the achievement in downstaging resection, we also write some as the guest editors of special issues to write this area. And the combination of different regional cancer therapy, and also we collected our 700 cases and found if test only test with only 5-year survival, only 23%. If test combined with radiofrequency, radioablation, tumor ablation, the 5-year survival will increase to 37%. Is nearly approach to the liver cancer resection, the survival. The final theme is metastasis and recurrence. The rate of metastasis and recurrence after radical resection for liver cancer in our liver cancer institute, thousands of cases showed the recurrence rate is as high as the 5-year recurrence rate is as high as 61%. That means more than 50% of the patients will have recurrence. Even for those patients with small liver cancer with early stage, the tumor size less than 5 centimeters, the 5-year recurrence rate is also 43%. So this gentleman, underwent liver cancer resection 40 years ago, also had a recurrence when he was 89 years old and died from liver cancer recurrence 3 years later. So metastasis and recurrence is a major issue for concurrent liver cancer. But the liver cancer is multi-gene, multi-step, and a multi-changing process with for the metastasis and recurrence, and a very different metastatic phenotype, and the body host microenvironment of the cancer, different cancer interaction may also influence the metastasis and the recurrence. So from 1993, our liver cancer study focused on the metastasis and the recurrence of liver cancer. So we established an animal model, and we established tumor and liver tissue cancer bank, and we not only focused on the cancer, but also we focused on the studies on the body host, liver cancer environment, and also we do a lot of experimental intervention to hope to find some intervention measures can be used, can be translated to the clinical use. First, in the world, we first established a metastatic model system from the liver cancer tissues, and we established 2 nude mice model. This model, like ARC-ID33, even this nude mice even die, one die, no metastasis. But ARC-ID20 is, even we do liver cancer resection, the mice with 100% lung metastasis and liver metastasis and even node spread. So this nude mice mimics the human beings' liver cancer, and mimics provide a very good platform for our experimental intervention model. And from this model, we also classify liver cancer cell lines. These cell lines has characteristic of 100% for lung metastasis. If we collect the cell lines implanted to the nude mice liver, has 100% for the lung metastasis. And from these cell lines, we further classified 4 cell lines, subtype of cell lines, and further different metastatic potential for such as MHC97 high have 100% for lung metastasis, but MHCC97L means only 40% of lung metastasis. And we keep further classify LCC LM6 for the lung metastasis 100%, lymph node 60%, but LM3 only no lymph node metastasis. So these different cell lines with different metastatic potential, but with similar genetic background. So this nude mice model and the cell lines provide very good platform for our liver cancer research. And we also have a huge biobank for the liver cancer, including tissue, blood cells, serum, plasma, urines. So liver cancer actually is a systemic disease, not big environment such as chemical, physical, biological factors, and also the body host. Body host include nervous, endocrine, immune, metabolism, and also liver cancer microenvironment also. So we not only focus on the liver cancer, but also should focus on another host or micro or macro environment. So recently, we have lots of studies on recurrence after liver cancer resection. We studied the origin of metastasis potential, such as circulating CTC tumor cells, circulating tumor cells, and also we found some key molecules related with recurrence and metastasis of liver cancer. And we also find some tumor marks or cells very important in the microenvironment for the tumor recurrence and the metastasis, and also found some mechanism important immunity of host and some new mechanism on tumor cell death, included apoptosis and autophagy, and some EMT, epithelial mesenchymal transition. So we found a lot of tumor marks in the blood or in the tissues for the can predict the liver cancer metastasis and recurrence after liver cancer resection. And we published a lot of papers, include New England Journal of Medicine, Lancet, and Hepatology, lots of papers. But the purpose of our study, especially for our clinicians, our surgeons, the purpose for our study, why we study basically do rescue research, our purpose is want to translate our basic results to the preclinical clinical use. The final purpose is can be used in the clinic after the clinical validation. Hope even my boss said, even maybe you have 100 results, even 1% results can be translated. That is okay. It's deserved to do research. So even in our nude mice model, we do lots of experiment intervention, use metastatic model. We found a lot of compounds or drugs can inhibit the tumor growth and metastasis in the nude mice, but only now interferon and Xeluda and sirolimus rapamycin can translate it to be used in our clinics. Now, such as interferon, we published this paper, found the high dose and long-term therapy with interferon alpha can really inhibit tumor growth and recurrence in our nude mice model bearing human hepatocellular carcinoma xenografts with high potential, high metastatic potential. This and also find interferon not only inhibits the tumor growth, but also can inhibit the angiogenesis induced by the tumor cells. And then we do randomized clinical trial to find and also find the interferon alpha really can delay the recurrence and improve the overall survival after critical resection. In our clinic, we really found some even patients used interferon after liver cancer resection. Also, some patients also have recurrence and metastasis. Why? We cooperated with NIH and found those patients liver cancer, only those liver cancer patients with micro 26A low expression can have high sensitivity to the interferon. This results published in New England Journal of Medicine. The conclusion of my talk, the future prospects of diagnosis and the treatment of liver cancer, the screening with new techniques such as plasma microRNAs can detect the early stage liver cancer, and the surgical treatment play an important role in liver cancer treatment because surgery, only patients who have surgery can have the longer overall survival. The local and biological treatment may bring new vitality to surgery treatment. Personalized and comprehensive combined treatment strategy also be as the main model for liver cancer treatment. The progress in translational medicine will improve the outcome of patients. So the primary prevention, the early diagnosis and treatment, and the study of biological characteristics are the three main roles to improve the overall survival of the liver cancer. So concurrent liver cancer is a great challenge for us, but hopeful. Thank you for your attention.
Thank you. When we go on to the fourth talk, with Dr. Sengar, who's going to talk to us about lymphoma therapies in India. Thank you.
Sure. Thank you. I did change my topic after your suggestion, Dr. Chow, that this will not be the correct audience to discuss the molecular profiling of lymphomas. So instead, I decided that I should speak what we face in day-to-day, what hurdles we get, and what successes we have got till now in cancer care and research. To begin with, greetings from India, and I really thank the organizers and Dr. Dave for making me part of this wonderful Global Cancer Symposium and giving me opportunity to represent India here. So, in my talk, before I begin, I must introduce myself. I'm a medical oncologist and I treat mainly heme malignancies. And this is the center where I work. One of my colleagues from the lab commented that it looks like Duke parking lot. And in this Duke parking lot, we treat roughly around 43,000 cancer patients annually, meaning new cancer registration. And in a day, we see roughly around 5,000 patients in OPD as follow-ups. Roughly 25 miles apart, we have our research center. And geographically speaking, we are located at the west coast of India in the state of Maharashtra. So I'll take you through the roadmap of my talk. In the first part, I'm going to talk about some basic facts about India and compare it with the rest of the world. To give you a perspective, when I talk about what hurdles we face, you need to know these facts. Considering that we are a developing country with a lot of pressing health issues, is there a really need for us to focus on something like cancer? And if yes, then how we are faring in terms of cancer care? Are we delivering it optimally? Are we delivering it universally? And where are we in terms of research with our limited resources? And at the end, I'm going to just give you some success stories of our war against cancer. So, as we see this, India is the largest democracy of the world, with very aptly called by the tourism industry as Incredible India. We have 28 states and 7 union territories under the federal government, which demonstrates a remarkable diversity in culture, in social issues, in terms of health, in terms of literacy. And to put it in simple words, there is a big north and south divide in India. Northern states are poorer, they are low in terms of their health care as compared to the states in south. So let's see what these basic facts, by basic facts, what I mean. India houses 1.2 billion of world population, that is roughly around 20%, in a land area which is little over than 2% of the whole world, high population density. We have a gender inequality because of ongoing female feticide, poor attention towards the health of the females in the family. We are low in literacy, 74%, as opposed to the developed countries where it's much above 95 to 98%. A lot of people are migrating from rural areas to city, but still in India, 70% of the population lives in villages. We have seen a lot of economic reforms from 1990 onwards, but still our GDP per capita is around $1,500 US, and if I compare it with the US, where it's 50,000 US dollars. So we are still lagging behind, and if we look at the sensitive way of looking at how many people are living below poverty line, we use this multi-dimensional poverty index, and roughly around 55% of Indians live below poverty line. So that's a lot. We are plenty in number, low on education, poor on income, and what it leads to? It leads to difficulty in accessing the basic amenities of life like safe water, leading to diarrheal diseases. We contribute almost 20% of the world's infant mortality and maternal mortality. We have a lot of infections like tuberculosis, malaria, HIV, resulting in high number of infectious disease-related deaths. So in this competing health problem era, where does the cancer should figure for us? Let me take you through next few slides to tell why we need to think about cancer. This is a slide which is showing that what are the stages of epidemiological and demographic transition. And India is experiencing what we call as protracted epidemiological transition. We are having declining death rates because of improvement in economy, better provision of food, and probably some improvement in healthcare, but the birth rates have not declined proportionately. So we are growing in number. We are growing at the rate of 1.5% per annum, and we are going to become soon 1.6 billion by 2020. Not only we are growing in number, we are living longer too. And by that, I mean that in last 30 years, the life expectancy has gone up from 45 years to 64 years for male and up to 68 years for female. So what this growing in numbers and living longer leads to? It leads to more and more number of people which are adding every year who are more than 65 years. And we all know that aging is a risk factor for cancer. So if you have population which is high in number, older, you are going to get more and more cancer. Not only just the aging, but with economy booming in India, there is a lot of lack of physical activity and there is a lot of obesity. So we have malnutrition at one hand and we have obesity at the other hand. And both these things are contributing towards rising incidence of cancer. And this is not just an imagination. This is a study which was conducted, and it looked at the deaths due to chronic diseases and injuries in India. And it clearly showed that from 2004 onwards, the deaths due to infection, maternal mortality, and infant mortality are gradually declining, but the mortality or the deaths due to non-communicable diseases is gradually increasing, and cancer is no exception. And this is reflected even in the data from the Globocan, which says that right now we have 1 million new cases in 2012, and we are going to touch 1.7 million by 2035. And we are going to have almost doubling of the cancer mortality or cancer death rates up to 1.2 million by 2035. And what it means for the rest of the world, we are contributing 8% of the cancer burden in terms of the cases as well as the cancer mortality. So after looking at this, I don't think we have any doubt that we need to focus on cancer. Yes, we need to. So then if we need to focus on cancer, how we are faring currently? And I'll just ask you to look at this particular graph, which is again from the Globocan. It shows basically incidence in the red bars and mortality in the blue bars across different regions of the world, starting the more developed region being above and less developed being lower. And what it shows, that the incidence is lesser in the least developed countries, but the mortality remains almost the same, resulting in high mortality incidence ratio, or also called as high case fatality ratio. And there we are. And why we are having this is just a reflection of suboptimal cancer care. And why I say, why suboptimal cancer care? And what are the factors which are responsible for this suboptimal cancer care? And this is something which I would just take your attention to. We have no idea at what we are dealing with. We are low on literacy, we are poor. There are a lot of social stigmas which are there which make people not go for cancer treatment even if they have access to. There is poor public funding, there is dismal health infrastructure, and to top it all, the drugs are too expensive to afford. Let me take you through each one of them separately. When we say lack of accurate estimation of cancer burden, what I mean by that? India started its cancer control program in 1975, and by 1982, we had a cancer registry program in place. But what is the status today? We have 27 cancer registries, both population and hospital-based, but the coverage is very poor. We cover only 7% of the whole population. Cancer is not a notifiable disease, so there is no mandatory reporting. We don't link to our death registries, and suppose even if we had linked, the cause of death reporting is so non-uniform that at times you get only cardiorespiratory arrest as a cause of death. So you will never know why that person has really died. And what this leads to? We are going for a war, and we have not known the strengths and weaknesses of our enemy. We don't know what our cancer burden is, and we don't know its true epidemiological attributes. Let's look at how literacy affects. This is a wonderful piece of study which was conducted from our center, and it basically looked at the cancer mortality and its association with literacy. And if you look at on the left-hand side, this shows the 8 standardized rates for total cancer deaths, for the tobacco-related cancer, for infection-related cancer, for both men and women. And a remarkable thing which appears over here, that the 8 standardized rates were almost 2.5 to 3 times higher if the person was illiterate as compared to those who were educated. So why it's so? It's because of lack of awareness. People don't know what early signs of cancer could be when they should be seeking a medical attention. And it is always correlated that illiteracy comes along with poverty. So they don't have access and they are not able to get the care on time. Let's look at how we are in terms of health infrastructure. If you look at the healthcare workforce, there is severe shortage. Just look at this number. Number of people, the allopathic physicians are 4 for 10,000 population. If you look at the trained sisters, they are less than 2 for 10,000 population. And you must be wondering why I've kept census separately and qualified practitioners separately. The reason for that is lot of people claim themselves as registered medical practitioners in India, and these are counted as allopathic practitioners, and they do not have any formal medical education. And these are the people to whom most of the rural people are going for treatment, be it cancer, be it any other disease. And obviously the care is not going to be good. In addition, there is a lot of alternative science, alternative medicine which is being practiced, like Unani, like Ayurveda, like homeopathy, which has not gone through the time-tested procedure of evidence-based medicine. And therefore, we don't know whether those drugs are really working or they are just placebo. So these are some problems which, when we look at our healthcare workforce, we face. And what is the situation about oncologists? Startling number. Less than 1 oncologist for 1 million population. So just wonder, with this growing cancer burden, how are we going to deal with and how we can provide an optimal cancer care? Not only just the healthcare workforce is a problem, it's a problem in terms of diagnostic and therapeutic services. One radiation center in India caters to a population of around 5 to 10 million, resulting in long waiting list, cancer progression, and obviously you are not going to get good outcomes. Let's come and see how we are funded, how we support our treatment, how the financing comes. A lot of financing of the healthcare is done either through the public sector, through employer-funded insurance, some through the private-funded insurance. But if you look at this pie chart, whooping 70% expenditure is from patients' own pocket. And if somebody wants to look at the indicators, the hard indicators, government spends less than 4% of its total expenditure on health. If you look at GDP, less than 1% of GDP is spent on health. So obviously it's going to be difficult. And if I want to put this in a proper perspective of a cancer care of this out-of-pocket expenditure, if a person in the rural area gets cancer, he needs to spend 35 to 50% of its annual household income to get treated. So that is where we stand. And so we have low penetration of insurance, low government expenditure, and which leads to high out-of-pocket spend. Let's put it in the perspective of social structure of India. We saw that almost 55% of our individuals are below poverty line, or what we call as they belong to lower class. And almost 300 million individuals live on less than $1 a day. So how are they going to get this cancer care where you have everything which is very expensive and they have difficulty in even making their ends meet? And situation has become even more worse by introduction of newer drugs. Looking at them, we get very excited because we look at the survival, but what it means for an individual who's earning less than $1 in a day, from where is he going to get a money to spend $60,000 US for a year for drugs like dasatinib or brentuximab? So that is where we stand. So what all this, whatever problems I have put into, how it translates into day-to-day care for us. So just listen to this, that we have a lady who lives in a rural area. She develops a lump in her breast. She doesn't know whether it could be cancer. She keeps ignoring it. And ultimately, she goes to a traditional healer who gives her some medicines. She doesn't get better. Then finally, she reaches to a primary health care where probably a doctor suspects that she can have cancer, and he refers her to a tertiary care center or a cancer hospital. She goes there, but she doesn't have money to get treated. She comes back only to die. So this is where we stand. And this is not a script from some Bollywood movie which I am giving you. This is a real fact which we have here. And this is a data which I'm going to show is from 5 Indian cancer hospitals. And we looked at what is the stage of presentation for breast cancer at the time of diagnosis. 70 to 90% of these patients come with a disease which is either regional or metastatic disease, as opposed to SEER data where it is less than 40%. So what it will lead to? It will lead to poor survival, and it is reflected. 5-year overall survival for breast cancer is less than 50% in India, as opposed to 89% from the SEER data. So why are we failing to summarize? We are not aware, both physician and the patients, that it could be cancer. There is poor accessibility, there is poor affordability, and all this leads to treatment refusal or abandonment. But the most distressing part is the lack of equity. 30% of the individuals have everything in their hand and they can get best of the treatment even in India, whereas the 70% of the individuals do not get access to even basic cancer care. So that is what is more worrisome. So we are not able to give basic cancer care, then why we should talk about cancer research? Yes, we should, because if we want to improve all these factors which have led to poor cancer care, we can do it only by doing research to address each one of them. So why do research? There is so much research going on around us. Just take the data and utilize it. We can't do that because we are different. And I'll tell you the reasons why we are different. If you look at India, if you look at the cancer subtype distribution, the top 3 cancers are breast cancer, cervical cancer, and oral cancer, as opposed to the world data where the lung cancer, breast cancer, and colorectal cancer are the top 3 ones. Not only the difference is between the world and India, within India we see a lot of difference in the epidemiology. If you look at the cancer incidence, different subtypes, distribution of different cancer subtypes within India, if you look at Kashmir, we see a lot of lung cancers over there. Himalayan belt people who are living in Himalayan belt having a lot of gallbladder cancer. People from the northeastern state are experiencing a lot of esophageal and stomach cancer. So a lot of variation within the country itself. And this is probably because of the risk factors which we are exposed to. In Kashmir, hookah smoking is very prevalent, which is probably the reason for the lung cancer. In the Himalayan belt, they use a specific cooking oil, and there is a very high incidence of gallstone disease. And in the northeastern state, there is a lot of smoked food which is used and which may be the reason for this high incidence of esophageal cancer. So we have differences in disease epidemiology within the country, differences in the risk factor, and not only just that, even the disease biology is different. We looked at our data of adenocarcinoma lung, and we evaluated the frequency of EGFR mutation, and it was almost 30%, much higher, almost double than what we see in the Western countries, but less than what we see in our neighboring Asian countries. So there is difference in disease biology. There is difference in the host itself. So we know that there is difference in terms of pharmacogenomics, which is going to translate into differential efficacy and differential toxicity, not just pharmacogenomics. We talk about nutrition. A lot of drugs which are highly protein bound, if you have a malnourished patient, you're going to get a lot of toxicity without much benefit. So you can't just take a trial from the Western world with all body surface area which has been calculated over there and with all pharmacokinetics over there and just apply it in India. You're not going to get the same results. And we always worry that we are reinventing the wheel. No, we are not reinventing the wheel. We are designing the drugs and the cancer treatment for our own patients. So we have constraints for research. We can do research, but there are constraints. Same thing what applies to cancer care also applies to cancer research. We don't have trained professionals to do research. We don't have funds to do research. In addition, there are ethical challenges. When we talk about randomized controlled clinical trial, we need to have a standard of care as control arm. And if a person is not participating in a clinical trial, he cannot afford that standard of care. So you enroll that patient into clinical trials so that you can get standard of care. What do you call it? Inducement, coercion. And that is which has been looked at by the regulatory authorities in a little bad manner, and we are facing its difficulties. Not only just having this coercion or inducement, problems with informed consenting. Many times in India, the attitude is paternalistic, meaning the doctor says the best, what is best for me is what doctor is telling me. Nobody explores what alternatives that person has if he or she doesn't participate in clinical trial. So there is a lot of difficulty with the informed consent, and regulatory authorities have not really looked at these issues very kindly, and they have gone on an overdrive, and we need now audiovisual consenting to participate in the clinical trials. So things are becoming tougher for us if you look at the scenario of cancer research in India. I've had a lot of problems. We can't do this, we can't do that, but yes, we did try, and we do have some success stories to tell of our war. And let's see how we have tackled with each one of the previous issues which I was alluding to. Lack of accurate indicators. National Cancer Registry Program had very poor coverage, and that's the reason why they decided to go ahead and develop what we call as Cancer Atlas. Cancer Atlas collected the data on the cancers diagnosed based on the histology or cytology from different pathology labs and the pathology centers to give a better estimate of what is happening in the country in terms of number of cancer cases and the types of cancer cases. And they really saw a beautiful distribution. There was a geographical distribution which was evident from this Cancer Atlas project, and it fueled a lot of epidemiological studies. So yes, you get, if you do something, you get a little better. Not only just the cancer incidence, even there is data to look at cancer mortality. Something which is very innovative way they have looked at cancer mortality. They took around 7,000 small areas which were considered to be representative of whole nation. 1.1 million households in these 7,000 areas were evaluated for deaths, and they tried putting the cause to each death by looking at their treatment charts and the charts available to them. And they utilized 130 physicians to do that. And the methodology they call as verbal autopsy. And by looking at this verbal autopsy, very interesting findings came. And 42% of deaths in India are happening because of, cancer deaths are happening because of tobacco-related cancers. Oral cancer is the biggest killer for men, and cervical cancer is the biggest killer for women. And I've already shown the data that illiteracy leads to poorer outcomes of cancer. And majority of patients who are dying due to cancer, 71% of them are dying in the age group of 30 to 69. So again, now you have got some background, some denominator to improve upon, and that is where these studies help. So how we have dealt with poor public funding and dismal health infrastructure, we made a lot of hue and cry to the government, and the government did something. It did improve the budget of National Cancer Control Program from 20 billion Indian rupees to 158 billion Indian rupees. So that is something as an achievement, but nothing as compared to what we really need. So what you can do in that scenario? You are having crunch of manpower, you are having crunch of money, so utilize them better. Utilize them better. You can't make, oncology seats. You can't just open up a new oncology center and train many people. So why not introduce oncology training in the graduate program and the postgraduate program so that these people can take care of the patients who go back from tertiary care centers at their native place and get a standard of care in a proper manner. So that is what we have suggested, and the Ministry of Health has looked at it favorably, and soon we are going to have these programs incorporated in our graduate and postgraduate training. Then, instead of treating advanced cancer, let's focus on prevention. It's going to pay a lot of dividends if you prevent cancer rather than treat advanced cancer or you detect them early. So what we can do in the area of primary prevention, if you look at the data that seems most exciting, 3 out of 5 cancer deaths in India are happening because of either tobacco or infection. Both are modifiable risk factors. So yes, you can go ahead and do primary prevention and you will get better results as compared to treating an advanced cancer. Major cancer killers are cervix, oral, and breast cancer. And all 3 of them have the means to get detected early and treated early so that you can utilize your resources in a better manner. And what Government of India has done, to do the tobacco control, we were the first one to take over after the Framework Convention, National Tobacco Control Program, to prevent the initiation, promote the cessation, and put heavy taxation on advertising and sales of tobacco. It's too early to see the benefits of something like this. It's going to be a long-drawn process, but it is cost-effective. $100 to save 1 tobacco cancer-related death. It's much cheaper than giving any other newer molecule for these patients. Cervical cancer vaccination, which can take care of a lot of problems in India with respect to cervical cancer incidence. 90% of them are because of HPV. We've just completed a trial for cervical cancer vaccination for HPV vaccination in for cervical cancer in India. It has run through a lot of difficulties, but I hope the government of India should take a note and should incorporate this into our national immunization program. So what have we done in detecting cancer early? And this is, I must allude to, because this was an ASCO plenary paper in 2013. The study was conducted by our center to assess the effect of visual inspection of acetic acid screening by primary healthcare workers on cervical cancer mortality. So what did they do? They screened around 150,000 females, randomized into 20 clusters. 10 clusters received screening in terms of cancer education and biennial VIA-based screening by primary healthcare workers. The control group received only cancer education. The incidence of cervical cancer neoplasia, incidence and mortality was monitored biennially, and those who were found positive were referred to Tata Memorial Hospital for their further management. And if we look at this, what it did to the individuals, 4 rounds of biennial VIA screening by primary health workers resulted in 31% reduction in cervical cancer mortality. There was no overdiagnosis, it was widely implementable, and if we utilize this particular methodology and implement it for the rest of the country, we can prevent 22,000 cervical cancer deaths. And if we go to the other developing world, then maybe 72,000 deaths can be prevented annually. 2 important things here which I have not written is that this screening was done by primary healthcare workers who had no formal medical education. So you don't need a medical professional to do the screening. And there was a very good agreement between the primary healthcare worker and the gynecologist detected cervical cancer, 0.82 kappa, which seems remarkable. And the cost was just less than $5 to screen 1 case. So it seems to be very cost effective. Similar results we have got in the oral cancer. In this particular cluster randomized trial, using visual inspection as a screening methodology could reduce cancer mortality by oral cancer up to the tune of 21%. And if we looked at high-risk patients, this reduction was 44%. And by high-risk, I mean that those who were using tobacco or those who were using alcohol, the mortality reduction was significant. So if we can apply same to the rest of the world, we could reduce 37,000 cancer deaths due to oral cancer. Seems promising. Somewhat similar data we have been getting through our currently ongoing cluster randomized trial for the breast cancer, where clinical breast examination is being utilized. Every 2 years, women between 40 to 60 years of age will be subjected to clinical breast examination, and it is again showing a promising data. It's almost as good as doing a mammography. So seems promising because we cannot install mammography machine. We don't have radiologists to read those mammography, and we cannot have that philanthropy which is going on in Brazil probably. We are not so good yet. So we need to have something which is more applicable to us. What have we done to deal with poverty? Any research there? Yes, if I look at our own hospital, it's a high-burden cancer hospital. We see roughly around 1,200 to 1,500 pediatric cancer patients, and a lot of them come not from Bombay, from outside Bombay and even outside India, from something like Bangladesh. And we saw a very disturbing trend. Almost 10% of these kids or their parents were abandoning the treatment because they came to a crowded center where there was no finances available, there was no accommodation, there was problems with the travel, there was loss of livelihood for the parents, they were illiterate, so they didn't know the importance of continuing treatment. There were language barriers, they could not communicate with the doctors, to the nurses, what they want, and there were obviously treatment-related problems. So what intervention we did? We just introduced a social support group. And what this social support group constituted of? There were doctors, there were medical social workers, there were psychologists, there were volunteers, data managers, nurses, and what they did? They just counseled the patient, they provided them with food, they provided them with cheap accommodation, they counseled them, they took care of their language barriers, communicated with the doctors and the other healthcare workers, and this resulted in significant reduction in treatment abandonment, almost 50% decrease within 1 year time period. So something very simple, but yes, it did work, and we hope to extend the same to other units in our own hospital. So what have we done as far as the expensive drugs are concerned? 2 important things have happened. 2 important decisions have been taken by the Government of India and the regulatory authorities. One, with respect to Gleevec, when it was not granted patent in India, giving the reason that it's not a drug which has improved the efficacy. It's just a newer version. It's just a beta-crystalline form. So you don't need a patent. And that gave an opportunity for rest of the companies, pharmaceutical companies in India, to produce more generics. Another important decision which has been taken recently is compulsory licensing, which has been granted to NATCO to make sorafenib. Cost of sorafenib in India per month was around $4,500. So the health activists said that this particular cost is too prohibitive and many patients cannot afford it. So then the regulatory authorities took note of it and granted compulsory license to NATCO to produce the same molecule at the cost of $150 with a rider that you cannot export this. It has to be for the sale in India. So yes, these two things have really made the difference in terms of accessibility for Indian patients, but there has been a concern whether it's going to hamper the innovation. I don't think so, because India constitutes only 1% of the rest of the world market, and just making some tweaking in the drug by just changing its structure without changing the efficacy, you can't call it as an innovation. It's just prolonging the life of the drug and getting more money. So that's not really an innovation. Another concern which everybody had, that if you produce so many biosimilars and generics, do they have the same quality? Is there a quality concern? And we just did a retrospective analysis comparing the generic version of anti-CD20 antibody, that is Reditex, produced by Dr. Reddy's laboratory, and compared it with the innovator, that is MabThera. And there was absolutely no difference we found in terms of progression-free survival or overall survival in these diffuse large B-cell lymphoma patients. Something similar we have observed with regards to generic imatinib in CML patients, and we are not seeing any difference as compared to the innovator. So quality, though, remains a concern, but as of now, we feel comfortable using these drugs, especially for patients who cannot afford anything else. So we have tried to optimize the cancer care through research, tackling all those points which we were concerned about and which is giving us the hurdles. So where do we stand in terms of global cancer scenario? We are in a position where we can give some and we can take some. We can give these innovative, cost-effective technology to the developing countries which are almost in our situation, and at the same time probably to even developed world, because even there the healthcare costs are skyrocketing. And what we can get in the bargain, we can take the help of global cancer leaders to identify the problems, to help us solve those problems in a better manner and earlier with their experience. And the way to go is international collaboration. And I must thank the Duke Global Health Institute for giving us this grant to pursue the study on molecular landscape of lymphoma in Indian subcontinent. So what do we do now? To tackle this slow epidemic of cancer, we need cooperative efforts from all over, commitment from policymakers, government, healthcare professionals, and patients. We need to have inbuilt evaluation within any policy with very robust indicators, with a constant feedback so that we can improve gradually. And what we need to do is to follow the example of HIV/AIDS, have a strong advocacy to get at the cancer. And we have hopes. We have just completed our elections, and we hope that the new government is going to give us more money for health. As usual, we are hopeful, but we must remember that the future is depending on what you do today, not just the future. Thank you.
Thank you. I'm going to invite the speakers to come up here and bring some chairs up so we can have a roundtable discussion. So I open this to the audience. If people have questions, themes to discuss. It's been a long afternoon, but there's been terrific talks. And anybody would like to start? Nobody has questions. Dr. Kastan.
Ted, since you started the day, I'll start with a question for you. What is the NCI's goal in global cancer? Why is it of interest at the national level, and how does it impact on national health for us to have an impact? And therefore, what's going to justify further investment?
Well, I mean, I think if we take, as the last speaker said, the example of HIV/AIDS, that is a global issue, and similarly, cancer is a global issue. It has different manifestations around the world, but we have to learn from one another, and so I think we have to, we can't just be in kind of Fortress America. We have to be understanding what the situation is in the rest of the world, and as our both with our commitment to research and our commitment to research, that translation of research into policy have got to be global.
So do those who like to check believe that?
Well, certainly, I mean, I think certainly Harold Varmus believes it. I think Francis Collins believes it. And, and we're trying to get the message, when we speak with policymakers. But I've been, pleasantly surprised in the relatively limited interactions I've had with members of Congress that, by and large, they and their staff understand that we live in a global society and that, health research is one of the strengths of the United States, and it improves our kind of global diplomacy to share that with the rest of the world and to learn from the rest of the world.
Okay, so kind of dovetailing off of that, I was just wondering how each of you kind of got the buy-in from the government to try to help create some of these programs, since that's kind of needed for sustained programs, especially ones that are so expensive as cancer care.
You ask my question? So we are supported by our hospital or Fudan University. I don't know the government support. I didn't feel the support from the government because our salary is paid by our hospital. So maybe really recently the government really put more money for the basic research. So I think maybe 10 times than much more time, around 10 times than 10 years ago. I think as because of the so much money put in the basic research, and even for the clinical trial, I think after this basic research or clinical trial research, I think we have more strong evidence for the clinical use for the patient. I think the government pay more attention and put more money really for the health system recently. That's how I feel.
But does does the Shanghai government pay the hospital? How does the hospital get the money for the cancer care?
But because our hospital is a public hospital, so we didn't, but the hospital must be supported by live by themselves. So one hand, the hospital must own some money, can support yourself. And maybe like our new building, maybe government will put some money to help us to maybe put some money, millions or dollars to support you to build a new building. But you need to apply, negotiate with the government officials.
Maybe the other panelists can
ask about the government. In our institution, the government, in general in Brazil, the government he writes on the paper. It's amazing what they do. You have 100% free of charge for every Brazilian person, and you can receive everything. But in a practical way, it doesn't work like that. And I think what we have done, was to get from the government pressure from the civil society. If he saw the civil society giving support to our institution and doing it very well, and everyone doing that, they become pressed to do the same. And the other good thing that you become more independent. If you have the civil society helping you, you can do a lot of things that you wish to do, but the government doesn't like because, for example, robotic surgery. We are going to open a robotic surgery in our institution. The government is against to do it, but he can't do it against Bartlett Cancer Hospital because he has a lot of support from the civil society and singers, and it's not going to be good for the government to have all the population against it. And I think it's work like that in Brazil.
So for us, it's government aid what we get, but a lot of the remaining things are self-sustaining. So we have a differential pricing where rich pay for the treatment of poor. So we charge them a little more so that we can subsidize the treatment for the patients who are poorer. So that is how we have been working. We do get some government aid, but it's not sufficient to run the hospital.
Thank you. So Manju, I have to say that today in Grand Rounds, in HEMONC Grand Rounds, the topic was cost of cancer care and how we don't address it with our patients in America. And after your brilliant talk, I have to say I feel, not only do I feel privileged, but spoiled for even complaining about anything that doesn't happen in my clinic. So kudos to you all at Tata who do such a great job. I think my question was to this, what you just answered about this Robin Hood method of treating patients where, really there's a difference in pricing for the rich versus the poor, but then that pays for cancer care for the poor. And you answered that question, but the second question I had was in terms of research and, encouraging younger fellows and medical students to, pick a research track during their fellowship. Rumor has it that the government of India does have the money, but when you're seeing 5,000 patients a day, how do you write a grant? How do you justify your time? Because over here, if I have a KO8 or an RO1, I'm only supposed to do 25% of clinical time. How do you justify that when you're seeing 5,000 patients a day? I mean, who does it?
This morning, the same discussion we were having, and we were discussing whether, how is your appraisal done? So I said that for us, it's taken for granted that you have to do clinical work, but your promotion is based on how much research you do. So you have to find your own time and see from where you can get. Ideally, when you write on a paper that you do 80% of, clinical work, 15% of your research, and 5% of education. So I would say that there is nothing like a protected research time for us where we can just do only research. It's just that we have to find time and do it because ultimately at the end you want to go up. You don't want to remain at that level. And it's not only just the pressure of promotion, it's just that something which gives you satisfaction is research. You've contributed something, and that's the reason why you have to find time. But I agree with you that the numbers are huge, and at times we wonder what we are doing to them.
A large percentage of the incidence of liver cancer is a combination of environmental factors, dietary factors, and viral factors, which means it's amenable to primary prevention. Could you tell us what is your institute doing? Do you have an arm of your institute involved in public communication or community-based activities to educate people on primary prevention? And I think you touched on government activities with respect to vaccine, but any other activities that you're involved in for primary prevention?
Recently, primary prevention measures really work in China, especially recent 20 years. From early 1990s, Chinese government have charge-free for the hepatitis for the babies for the hepatitis B vaccination. So the hepatitis B virus carrier has decreased to 7% of the normal population, because 20 years ago, maybe 10%. So I believe 20 years later or 30 years later, the liver cancer incidence will dramatically drop down. So and also we educated in the newspaper media, and for those patients who has liver cancer family history, or who are hepatitis B virus positive, and encourage this population to have a physical examination at least once a year, to using alpha-fetoprotein test, very cheap, and also ultrasound. Ultrasound is very cheap in China, only maybe $20 or $30, not as high as here in the States. So this very cheap, simple combination test can detect more than 90% of liver cancer. So I think the primary prevention measures have been taken in China. So this is also very effective. You can see the effect 20 years later, maybe, I believe.
Do you still consider aflatoxin a risk factor in China?
Aflatoxin is not as common as before because the standard level is higher. It's not as long time ago, very poor, they even eat the fruits with aflatoxin, even with aflatoxin contaminated. But recently, I think the water pollution and also the aflatoxin food problems has been solved. Most of it have been solved, I think.
Hi. So I don't have a question per se, but I have a couple of comments. First, all the presentations were excellent. Particularly congratulate those of you for whom English is not your first language. What an excellent job you did in your presentations, and I appreciate that very much. As we look at cancer as a global burden, as a global disease, one of the components that I think sometimes we don't spend enough time thinking about is the workforce that's going to be required to care for, diagnose, from prevention to palliative care, end-of-life care. We know, for instance, in the United States, that we have a huge future potential shortage of oncologists, of nurses, without yet some real clear-cut strategies for replacement of those specialists, except by borrowing from other countries. And that worries me because the global burden in other countries, as you so wonderfully presented here, eloquently presented here, it's not going to be smart to take from a country to another country, but it is a problem. It's a problem in nursing. I'm a nurse. I teach over at the School of Nursing. And I think we have to be very sensitive to that. And so while we look at research and care delivery, I think the workforce also has to be thought about. And how can we, from the developed countries, the high resource countries, work with middle and low income countries on the needs there as well. Thanks.
Would our panelists want to comment? Are there efforts nationally for workforce enhancement in cancer?
Well, I mean, the U.S. government has made a commitment in Africa to help with medical education and nursing education in certain countries. So I think there is a recognition about how important this is. But somehow we have to get the message across to all the countries of the world that they need to train their own, workforce across a variety of disciplines, as well as to pay them an adequate salary and treat them well, because we certainly have seen a lot of migration from one country to another because people the work situation is untenable and the salaries are not ones on which you can adequately raise a family. So it's both a question of improving the training as well as making sure that people are treated appropriately and paid appropriately.
Well, I have a question for Dr. Sengar. we don't know the oral cancer is very high in India, and you mentioned there are very simple methods can detect or prevent. Is there any national program or campaign try to prevent oral cancer, or any physician reach out to the community, particularly the high risk area?
So one is obviously the tobacco control program, but when we look at oral cancer, there are certain outreach programs we are having run by Tata Memorial Hospital, and few of the outreach centers we have, which are like, one is Barshi and another is Chiploon, what we have. And yes, we are, looking at oral cancers, picking them up early and then treating them. But other than that, if you are discussing in terms of national level, no, there is nothing as of now which is there at national level. Despite having such wonderful results from that visual inspection study, it's not yet been applied nationally.
Other questions? Yes.
Hi, I'm one of the Duke Oncology Fellows, and this question is for those of you who treat patients with chemotherapy. How do you deal with giving chemotherapy to patients who may live in places where they don't have access to clean water, or they have a high risk of getting infections, since chemotherapy may lead to immunosuppression for weeks or even months?
This is what we do day in and day out, and I would say that almost more than 25% of patients who are seen in our hospital belong to that class. Those who receive chemotherapy in the hospital, you talk about cleanliness, you talk about hand hygiene over there, and they go out and they are sitting outside on the footpath when you go back finishing your work from the hospital. Yes, it's a challenge, but unfortunately we can only tell them, we can only provide them with some alternative accommodation which is cleaner, provide them with something which is more hygienic, but beyond that, we are tied up. So we still go ahead and we treat, because we cannot refuse just on the ground that they will not have access to clean water or clean facilities to stay, but this is what we've been doing. So we have a problem. And Bombay, as you saw, the size of the hospital itself is so small. To get accommodation in the city of Bombay is even more difficult, even if we want to. But yes, we are trying at our own level through several NGOs and volunteers to get these things in place.
But if you look at Africa, for example, if you have AML, you're not induced.
Yeah, so exactly. So we have a lot of, burden of gram-negative sepsis, and it's becoming, difficult to deal with because it's resistant to even carbapenem is coming up now. So all these are problems which are worrisome for us, especially in the situations where we treat patients. In our own little ways, we have been trying to tackle it to improve the situation, and we have become better. If I say that in last 2 years, we've seen a declining trend in these infections by, widespread use of hand hygiene, hand washing amongst the healthcare force as well as the patient and their relatives. I think the education is going to go a long way in, dealing with most of it.
What about in Brazil?
Hello. You want to explain much better? He's the head of clinical oncology of, he leads with the patient using chemotherapy. And I don't think we have this problem, such a big problem in Brazil, in Barretos at least, because if they need to have a place for them to stay in our region, next to our city, and we don't leave the patient back to their home before they are reasonable, okay, and the people that live far away, they stay most of their time in Barretos until they finish their treatment, and I don't think they have this kind of treatment, this problem over there.
In China?
In China, chemotherapy usually maybe 50% in the OPD and 50% maybe in the hospital. In our hospital, I think especially for those patients with side effects, then we're admitted to the hospital. Most of patients were in the OPT, we can deal with that. Nurses can doctors write prescription and the patients receive the chemotherapy in the OPT.
But if they get neutropenic, what happens? Do they live locally?
They live locally, but in our hospital, maybe in our for liver cancer, maybe 70% are from the whole country, because we are famous for that. But for the normal colorectal and stomach, maybe more than 50% are around the not local, also even from far away. But for those patients, sometimes they bring the prescription, bring the drug back to the local. It's different.
My question is for Dr. Trimble. How are the prices of anti-cancer drugs regulated in USA? And does either NCI or FDA have a role in regulation of drug prices?
That's a very good question. Some branches of the U.S. government can negotiate with companies. I mean, the Veterans Administration and the Defense Department are allowed by law to negotiate on prices. Medicare is not allowed to negotiate. In terms of biomedical research sponsored by the NIH, at one time we were allowed to, if we licensed technology to companies, we were allowed to put in that licensing agreement a clause requiring reasonable pricing. But Congress, in its wisdom, took that clause, and so that is no longer. So we're not allowed to, in the biggest programs, whether it's research funded by NIH or Medicare, to negotiate on price.
Hi, I'm a graduate student from Dr. Chow's lab, and I have the question for the professors from the developing country. And after this talk, give me the impression that from the clinical trial data, how should we compare it to the American data? Because each country have their own specific conditions and have different treatments and diagnosis protocols. And also, shall we consider the bias caused by the patient's accessibility and also availability? Thank you.
So if we say that, how we compare, we all want to, get the best results, and with our own limitations and constraints. So we are not really comparing in terms of, how we are with respect to United States or, Western Europe. What we want is what is achievable with us, and we want to be there with our limited resources. And that is what we have been, trying to do, getting there with our limited resources.
In Bartlett, what we're trying to do is nowadays the communications become very widespread, and we follow the same standard all over the world, and we try to comparison our result, each clinical trial, everything with international protocol, and you follow, I think they are visiting, seeing, doing exactly the same. I think it's a lot of things done similar in the world. What we saw, for example, if you compare our children with cancer with this cancer hospital, in the USA, what's the famous?
St. Jude's.
St. Jude's. If we are compare our result with St. Jude's, we are always 10% less or 15% less. But what we saw, that was not because of the treatment. If we compare the results of treatment by stage, we have the same result. What's happening, they are coming more advanced stage, and this is something that we have to work very hard, because our treatment is going almost the same as USA, and the clinical trial design is almost the same, but our patients are coming more in advanced stage.
because I think it is easy to compare the results from different countries, because such as liver cancer, for example, liver cancer measures how to treat liver cancer. The therapy is same, transplantation, operation, or radiofrequency, or chemoembolization. I think the different countries that the measure is the same, but the difference is how to treat. Maybe the concept is different. So I think because you can say the literature, you can review the literature, you can compare how the difference. I think it is easier to compare.
I should add that this is something that both the academic community in general, as well as in my own case, NCI, has really tried to make sure that we do talk the same language when it comes to treatment and diagnosis. So we try to follow the WHO IARC pathology blue books in terms of diagnosis, follow the same staging manuals, the whole common toxicity adverse event reporting system is something that NCI put a lot of effort to harmonize so that everybody uses the same language to report. I mean, in terms of patient definition and in terms of outcome definition.
Let's say Dr. Kastan and the Duke leaders say, let us ask whatever you want to improve the cancer patient care at your institute, other than giving you money. What would be your request?
What I would like to have each time more education and more administration, more training for the underprivileged people. This is, I think, the process today. They are almost the same. You can buy the good quality, at least in Brazil, the equipment but it's difficult. Behavioral science, it's important nowadays. You have to understand what the poor are thinking, how we can get a good message to them, and how can bring them to the best way to receive this information. And I don't think it's not just education. I think it's education, training, and mostly administration. I think the developed country there don't have a good administration process. And I think even USA in the health, you have to move much better in administration. Health and education are the worst administration process in the world if you discuss about it. And I think that this 3 steps for me should be the best thing, because I forgot to talk, for example, who introduced the breast cancer screening in Sweden was the second country after USA, was not the doctor, was not the NCI of then, was the population, the women who entered the parliament because of their education, of their learning. They said, we want to have mammography to every women in this country. And I think we have to find how to get the right message to the poor and how to help them to do the administration.
Obviously, the education and training. But what is more relevant is analyzing our own system. I would require the help to analyze the system, what we are facing, and give us suggestions at how we can improve over there by giving solutions which are relevant to our scenario, not to tell us that you can use this particular regimen and probably treat acute lymphoblastic leukemia and you will get 90% cure rates. That would not be right. What I need is somebody who's analyzing the system and giving me a solution which is going to work for my country and for my hospital.
In my hospital, many programs to train us, to help us to improve, such as the way in our hospital, before your promotion to be the professor, you must have the experience to go abroad. So this fields can be covered by the hospital. So this is entitlement. This is the condition. If you need to promote, you need to go abroad, and also the hospital will cover your money. So many different programs to encourage you to learn, to improve, I think.
So I'm going to ask: has anybody's countries used social media to push? No. Social media to push for cancer therapies, and in these low to middle income countries. I know in Brazil there's a lot of involvement of the people who are entertainers and very sort of important people. I don't know if there are people who are on social media pushing this.
Yeah, another thing that I would like to have you ask, to have hundreds of our hospital in Brazil, the same mission, all over Brazil and Latin America and after. I think you have a good example what we are doing over there. But about social media, I think you have several ways how to make it happen, such as if you do the good, you do the best, you try to do the best. If you translate to it, what's happened, just for example, they start to speak mouth by mouth to another one, and after that we become more, you use like singers, famous singers to help they give their picture, you can give their message. We use like the famous television channel, they give, look, the mobile unit of Bartlett's Cancer Hospital is going to be in that city, and we are using the television, and we are trying now to use the student at school to be a mini agent, community agent, to talk to their mothers, say, look, you are using the school nowadays to try to get this language to tell to their mother. But what I think it's important is to teach them and to offer to them the possibility to do the exam, not just get the information. And we are using SMS, I don't know, by send message to when the poor people has to repeat the exam they received, because cell phone, it's very common in Brazil today. Everyone has a cell phone. And the next dream, I didn't put over there, I think if you get that, it's going to be amazing. We want to have a museum just for the kids, and when they are coming and are going to learn about to be a doctor, to be a cancer, how to do cancer prevention, how about primary cancer disease, we are just thinking about it.
All of you have spoken about data in some way or another, about registries or following up on outcomes or screening levels. And when we think on a systems level about how to improve cancer care delivery, we need a lot of data. We need the clinical data, the molecular data about how cancer is different in all of your countries. Also financial data, geographic data, where are your patients coming from, where would you like the next set of treatment centers to be. So in my experience, that data is not all stored together at all, and it may be different people in the hospital, different levels of administration or technicians who have access. So could you all talk a little bit about where that data is in your system and what you would think it would take to bring it together, whether that's technical expertise or teams of people that have access to it?
Each one of us has been, storing the data for individual things separately. It's all very vertical. There is no, horizontal collaboration between two sets of people. So we all have data, but no one has, put it together to come out with a, equation which is going to give you a solution for your own situation. So you're right, that it's no one place which is, there where we have data. But yes, if we want to do it, we have everything to put in place.
And as I understood, the IT people should be something like that, the people that work in technology. I think there is a lot of improvement to do that in the cancer. And for example, I went to Dana-Farber. I don't remember the exact number. Like they have 1,400 people work in the IT program, and over there I can't have this number of people working in my hospital just doing it. But I think it's very important to bring the engineering to work in the hospital, and it's very important to bring the education people and the administration people from the industry to come more together with us. I think what I told about health and education was a publication from Harvard Business Review. They were study all the fields in the world, and they said the health and education are and I think the IT people should do amazing things, but I don't think in their graduation they learn about health or they learn about it.
Our patients source is maybe 30% of liver cancer patients are from the screen result, maybe. So recently, the early stage liver cancer rates increased a lot. So, but also have around 70%, even they have symptoms, they can go to the hospital. So different source, maybe the results is different. So in our Liver Cancer Institute, we have nearly more than 95% for the patient have follow-up data. So we have collected 20,000 liver cancer patients for the follow-up data, even for the 30 years, 40 years. And we have 3 coordinators to do this special work just for follow-up. So.
One of the things that we've observed is the importance of countries developing unique patient identifier numbers that can be associated with the health records. And one reason why we've seen so much great data coming out of Scandinavia and the Netherlands is that they have such a number and linked to someone's interaction with the health system, including whether they filled a prescription and their clinic visits and their hospital visits and their pathology report and the death registry, so that you can do that analysis. You can see where you need the hospitals, where you need to place the clinics. So it's something that, India, for example, is now creating a unique patient identifier associated with biometrics, with an iris scan, and they've gotten 500 million people into that system. Now, they're not using it yet for health, but they can use it for health. And so we need to encourage all countries to figure out how to do that. I mean, we don't do it right in the U.S., in part because we started to do it using Social Security number, but then we realized that for Social Security number is used for so many different things that that's not useful. I mean, it's not right for that to link health records. But we can't tell in the United States if you've had a mammogram in 2 different hospitals, you can have them a week apart, and we can't link those records. We don't know who had pap smears in the U.S. unless you belong to Kaiser or something
like that. So let me ask one question, which is that there's a sense that there is this evolving tragedy in the next 10, 20 years in terms of global mortality for cancer. And do your respective governments have a sense of this urgency, or is that just local?
No, so I think, for example, Brazil now bought 97 linear accelerator from Varia, and suddenly it took quite a long time to understand that they should have more equipment, and suddenly they start to buy all this equipment to distribute all over the country. It's I think in general the government, they are a little bit slow in taking decision. I think it's good for the Brazilian people to have the opportunity not to pay anything for any kind of treatment because the government is responsible for it. The idea was amazing, but I think they have to improve this idea and talk about cancer. I think I received an email. I can't forget the word, tsunami of human suffering from the president of American Society. He used this expression. It's going to happen in this developed country. It's going to press the media, and it's going to press to have more kind of way how to do it more in a reasonable way, and to this country, at least in Brazil, will have to create the future. We have to have this good partnership like we're trying to do with Duke, and to get the best knowledge and to get this information to the government. And but I think I do believe that you are in a good way with the government. Because information today is so fast that's impossible for the government. And at least in Brazil, we don't have religious problem, and we don't have this kind of thing. It's become much easier for you to spread. What you need is more information, more education, and all of these things. But I think the disease is going to press the government to be more fast.
So India has started looking at non-communicable diseases, and they have started a control program for that. And over the last few years, I would say the 12th five-year plan, where we have increased the budget remarkably for National Cancer Control Program. So yes, there is an intention. We have to see how much it gets implemented. That is going to be more relevant. But yes, they are giving more importance gradually to cancer.
Money for cancer, whether whether the government believes the cancer problem.
The government, the money is big, but from the local is not so big, because usually in our liver cancer institute every year, I think nearly several millions US dollars from the government, and less than 1 million from the local in Shanghai government. So.
I think we've seen in many countries just the importance of public spokespeople to talk about cancer. I mean, just as we saw when Betty Ford and Happy Rockefeller in this country developed breast cancer and acknowledged in public that they had breast cancer, they're being treated for breast cancer, then all of a sudden it became okay to talk about cancer, and the number of women undergoing breast cancer screening went up. And so we've seen that in a number of other countries, whether it's a first lady or someone who's a prominent sports figure or entertainer who's had a relative develop cancer, then they become a spokesperson to say cancer is important, and our government and our country needs to do something about this.
My question is for Dr. Zhou from China. My name is Yuan Song, and I have an informatics background, so I'm particularly interested in the disruptive innovation happens in healthcare delivery model. So my question is, based on what I know in China the healthcare delivery model is like very much like shopping. People get sick and then they go to hospital directly to seek their diagnostic or treatment from doctors. So I was wondering if there's any novel program happening in China or will happen in China to optimize the healthcare delivery model, the traditional delivery model.
The tradition is very different to change because although the government says very difficult, Chinese patients is very difficult to see the doctors. But I think maybe Chinese patients maybe the easiest is in the world to see the doctors, because even such as liver cancer patient, if the patient can't see the doctor, 1 week later, they will say this is very difficult. It is quite different from the Hong Kong, from even Taiwan. You can say even you suffer from liver cancer today, maybe you can see the doctor, have appointment 3 weeks later, and months later, but the patient acquired. But if we mail in China, if 3 days or 1 week, they will maybe protest, maybe. So this is different. But I think China, mainland China, now the system is improved a lot because all the traditionally Chinese patients are very likely, even very small disease, they like to go to the big hospital, even very small, even go catch cold, they will go to the hospital. So very difficult to see the doctors. So I think as long after the education to the people, even if you have small disease, you can just see the doctor locally. I think the health system is changing now, such as if you small disease or not so serious disease, you can go to the small hospitals or local hospitals, and maybe the government may coverage more than if you go to the big hospital. I think the system are changed little and little.
Any other comments or questions? If not, I really would like to thank our panelists and invite Dr. Merson for some concluding remarks.
Well, thank you. Let me say first, I appreciate not only all of you for joining us today, but hanging in there all day, all afternoon. It's wonderful so many of you have stayed. It's a very important topic, and I thought the discussion and presentations were wonderful. I want to thank Nelson and John for organizing today, lining up our speakers and the staff of the two institutes. Of course, I want to pay a special thanks to Ted Trimble, who came here. He has a very busy life, I assure you, with multiple, I'm sure, invitations every day, and I appreciate your coming here, Ted. And of course, our visitors, our colleagues from Brazil, India, and China. I thought I'd just spend a few minutes reflecting a little bit on what I heard each of you say, and then maybe leave you with a little controversial thing to think about. Ted, I heard from you, the most important thing I heard from you was global disease, global solution. And if you keep saying that around the world, it'll make a big difference, more than anything else. Certainly, your mentioning of career tracks and low-cost technology partnerships, going after hanging fruit. Your reference to infectious disease and tobacco. Those are real hanging fruits for cancer. And the relationship to HIV, which I will come back to at the end. One thing that struck me, for those of you who know the AIDS history, some of the leading physicians who got into AIDS came from oncology. And now we need these AIDS physicians who started in oncology to go back to oncology and do what they did for AIDS for oncology. Many of the people I know, Ted, started as oncologists who came into HIV. John Bartlett, speaking on behalf of Africa, I think reminded us so well how much Duke is doing in Africa. It's a place where we have over 100 faculty working on different projects. We have an Africa initiative at Duke, which John heads up. I think, John, you also reminded us very importantly of the complexity of cancer care. It's not just an oncologist, and how in a limited setting you can bring about all that care, all those specialties that you need, to me is going to be a real challenge. But I think at least there are more pathologists than there were, and we need more, obviously. And this is where the idea of the D43 grants, I think, could be very helpful. Edmundo, I don't think I've ever met anyone who has more passion for his people than you. I mean, you can even round up 35,000 cattle to auction. That's just remarkable. I don't think I've ever heard that. Some of you from the Midwest, what do you think of that in terms of philanthropy? Mobile units in the Amazon region, that's no easy feat. I've been there and I know how hard that can be. So all I can say is you've really shown us what can be done with incredible passion and a desire to just, care for those who really need care for cancer. You're the model for the world right now from what I've seen. And I really admire all you've done, and I hope, maybe when you're through taking care of Brazil, you can just go around the world and go country by country and do what you've done in Brazil. John Chu, you really, I think what I took from your talk was, you take a disease like liver cancer, which had such a deep impact in China, and you've turned it around. I mean, vaccination and your treatment plan, you've shown, to me, I would use in your case hope. You've given us hope on what you can do when you have a serious national problem and you can turn it around. And I give you great credit for that, and you're not stopping. You made progress on vaccination and then surgical resection and early surgical resection. You went from biomarkers to signatures, and now you're getting involved in downsizing or downstaging, which is a great term. I hadn't heard that. I'm not an oncologist, but this idea of downstaging in the way of approaching cancer is very innovative. So congratulations on your success. And then, of course, Manju, you fooled us because she started off by telling us how terrible India was, and then you brilliantly showed us what you can do. And for me, you showed us the beauty of strategy and creativity in dealing with the problem of cancer in a tough country. But you're a country that eradicated polio. Before that, you eradicated smallpox. So I don't give up on India, not in the slightest. And if it wasn't for India, we wouldn't have 6 million, or what is it now, 8 million people on antiretroviral drugs around the world. Let's remember that. So, but you beautifully showed us how you've done everything but draw an atlas, to do national surveys, to focusing on prevention, and you're cleverly doing it on 3 cancers that really make a difference in your country. And I give you credit for calling us all to the attention of stigma, which obviously remains a real major challenge when it comes to cancer in many parts of the world. When I grew up, it was a challenge in this country. We didn't talk about, my neighbor had cancer, we didn't talk about it. It's not the case anymore. So it takes time. Once people have hope, the stigma will diminish. So then I would just say, on this question that you asked, Nelson, about where we go from here globally, how do we make it happen? So some of you may know that way back in my history, I ran the global program on AIDS in WHO. And so I spent a lot of time thinking about how to mount the global effort against the AIDS pandemic. And since, thanks to American Airlines, I didn't get much sleep last night, I've been thinking, sitting over here, about what I might do if I were in charge of some kind of a global cancer program. And I will say that the progress we made in AIDS has come from 4 ingredients globally. The first was incredible advocacy. Now, in the case of AIDS, we had ACT UP taking over the FDA. I'm not sure the FDA would like that again, but we certainly mounted a war on cancer in this country. For whatever reason, it was mounted. NCI is the only institute that reports directly to the president. So we do have there's something special about cancer, I think, that lends itself to advocacy. Many people have had or know people with cancer. And I think if you ask me what advocacy group has I guess, learned from the AIDS activists, it's been the breast cancer activists. And I think they've shown us what you can do, begun to show us what you can do in advocacy for cancer. The NGOs are key. Please remember, it took 20 years for people to take the AIDS pandemic seriously. 20 million people had to die. The price of antiretroviral drugs had to go up to $15,000 a year. And And finally, when we had an international AIDS conference in Durban, in South Africa, the world woke up. It took 20 years. So you have to be patient with your advocacy, but I do believe that's the first ingredient that will change to make cancer a global movement. We need some really powerful NGOs, and as Ted mentioned, we need some strong, outspoken advocates. Second thing that made a difference in the AIDS pandemic was we took some aspects of prevention seriously, and I think I think certainly condoms was the obvious one, although that still today has its challenges. But certainly we certainly advocately promoted condoms and needle exchange and ways of preventing HIV. But we have a similar situation here in tobacco. I mean, the biggest killer of any on the planet, which somehow still, as we heard, even there are still signs as you get off the airport, as John said, or when you're driving around town in Moshi. That's a tragedy. I mean, that's just a tragedy. And of course, vaccination. We can vaccinate away quite a bit of cancer right now. So we have some obvious parallels with HIV. Now, in HIV, of course, we worked on cheap diagnostic tests. But what we need to do in cancer is to work on as cheap as we can, and NIH is doing some of that, diagnostic tests for the main cancers. What you call low. You have a program on that now, low-cost technology. We need innovation, as we heard. But there's no reason why we can't bring down the cost of diagnostics. We just have to we just want to do it, and we've got to bring in the people who know how to do it using modern technologies. And then, of course, the third ingredient was AIDS. Which was a big one, was treatment. We got the price of drugs down from $15,000 a year to $100 a year. $15,000 a year to $100 a year. The companies are still making profit. Now, we need to thank the government. Well, we have to thank the Indian manufacturers for that. As you heard the story today, they have a remarkable way of making very effective drugs, and I'm glad you told that story, at a very low price. Now, I know I'm going to upset pharma when I say that. I don't mean to. I just want equity. And I think that if we can do what you've done in India for those cancer drugs, and we can make other drugs that inexpensive, and be willing to use drugs that are perhaps not as perfect as the drugs we use now in this country, but drugs that might have worked almost as well and are much cheaper and off patent now, I think we can make real progress on treatment in cancer. And then the fourth ingredient that made a difference in AIDS was an international structure. We had UNAIDS, we had the Global Fund that really mobilized governments, mobilized institutions internationally to do something about cancer. Now, we don't really have that right now. We have something called NCDs. And NCDs, first of all, they're not really non-communicable, some of them, which is confusing. And secondly, there are a bunch of things right now, and they all get grouped together, and we don't know what to do with it, right? We have cancer, we have heart disease, we have mental health, we have diabetes, and we can go on, kidney disease, et cetera. But if we put a special emphasis on cancer, not to say the other NCDs are unimportant, but then I think you have the fourth ingredient, and if you had some kind of international cancer institution or coalition, that could be the fourth ingredient. Now, I don't want to sound naive. AIDS is a single disease. Obviously, cancer, there are multiple cancers. And, you know, the treatment of AIDS and all the different, as John has pointed out, all the different expertise you need for treatment of cancer are quite different. You need surgeons, you need oncologists, you need radiologists. I understand all that. But nevertheless, I think if we focus on the cancers that really cause the greatest mortality and morbidity, we could have an interesting global movement. So that's my prescription, Nelson, for how governments could make a difference. And I'm sure we could poke holes in it, but at least I was trying to lay out there for, before we all leave, that there's great hope. Think where we were 10 years ago. Nobody took, even 5 years ago, most people didn't take global cancer very seriously. I don't know, Ted, when NCI really set up your center 4 or 5 years ago at most. I don't know, but two years ago. Okay, so I think we have to. These things take time, but I see tremendous possibilities in global cancer. Whether it's the prescription I laid out or someone else have a better prescription, it doesn't really matter to me. But I can tell you that if you had been in the trenches in AIDS, and like some people in this room in the 1980s or the 1990s, you would never dream where we are today. So I think that's the mind frame and the positive perspective we have to have with regard to cancer. I really do believe that tremendous progress can be made in the next 5 to 10 years if there's a global commitment to do so. And the last thing I would say is I think the marriage of global health and global cancer is a very good one, because I think in the cancer field we've built up so much expertise and great science, and if you marry that with the global equity that those of us working in global health care so much about, you really have an ideal marriage that can make a big difference in this field. So those of you who are here, and I assume you're here because you really care about this topic, and so I hope you will all stay engaged and we can make great progress in the years ahead. And thanks again for coming. Thanks to those who organized it, and let's have another symposium in not soon after this, and I'll bet we'll make more progress. Thanks a lot.